Welcome to USMLEFasttrack.com.
This video is going to cover the entire Neurology chapter starting on page 408 from the first aid for the USMLE Step 1 2013 edition. Neural development. How is the neural plate formed? The neural plate is formed when the notochord induces the overlying ectoderm to differentiate into neuroectoderm. What does the neural plate give rise to? The neural plate gives rise to the neural tube and the neural crest cells. What is the end result of notochord? The end result of notochord is to become the nucleus pulposus of the intervertebral disc in adults. What is another name for dorsal side of the neural tube? Another name for the dorsal side of the neural tube is the alar plate or the alar lamina. What is another name for ventral side of the neural tube? The ventral side of the neural tube is the basal plate or the basal lamina. What type of neurons are contained in the alar plate? The alar plate contains the sensory neurons. What type of neurons are contained in the basal plate? In the basal plate there are motor neurons. Regional specification of a developing brain. What are the three primary vesicles of a developing brain? The three primary vesicles are the forebrain, also known as the prosencephalon, the midbrain, also known as the mesencephalon, and the hindbrain, known as the rhombencephalon. Also in this picture you could see the wall and the cavity. What are the five secondary vesicles of a developing brain? The five secondary vesicles of a developing brain includes telencephalon, the diencephalon, the mesencephalon, the metencephalon, and the myelencephalon. What are the two vesicles that the forebrain or the prosencephalon give rise to? The forebrain or the prosencephalon gives rise to telencephalon and the diencephalon. What are the two secondary vesicles that the hindbrain or the rhombencephalon give rise to? The hindbrain or the rhombencephalon gives rise to metencephalon and the myelencephalon. What is an adult derivative of the telencephalon wall? The telencephalon wall becomes the cerebral hemispheres. What is an adult derivative of the telencephalon cavity? The adult derivative of a telencephalon cavity is the lateral ventricles. What is an adult derivative of the diencephalon wall? The adult derivative of a diencephalon wall is the thalamus. What is an adult derivative of a diencephalon cavity? The adult derivative of a diencephalon cavity is the third ventricle. What is an adult derivative of a mesencephalon wall? The adult derivative of a mesencephalon wall is the midbrain. What is an adult derivative of a mesencephalon cavity? The adult derivative of mesencephalon cavity is the aqueduct. What is an adult derivative of the metencephalon wall? The adult derivative of a metencephalon wall is the pons and the cerebellum. What is an adult derivative of the metencephalon cavities? The adult derivative of metencephalon cavity is the upper part of the fourth ventricle. What is an adult derivative of a myelencephalon wall? Adult derivative of a myelencephalon wall is the medulla. What is the adult derivative of the myelencephalon cavities? The adult derivatives of the myelencephalon cavities is the lower part of the fourth ventricle. This page is not included in the first aid, but it's helpful in understanding everything we talked about in page 408. In this picture you see the ectoderm that thickens to become the neural plate. In the neural plate, its folds will rise and fuse to form the neural tube. The neural tube then will form the primary brain vesicles such as the prosencephalon, the mesencephalon, and the rhombencephalon. These structures then differentiate. The prosencephalon will differentiate into telencephalon and the diencephalon. The mesencephalon stays mesencephalon, and the rhombencephalon becomes metencephalon and the myelencephalon. The telencephalon then differentiates into becoming the cerebral cortex and the basal nuclei. The diencephalon differentiates into becoming the retina of the eye, the thalamus, and the hypothalamus. The mesencephalon differentiates into the midbrain and the superior colliculi and the inferior colliculi. The metencephalon differentiates into the pons and the cerebellum, and the myelencephalon becomes the medulla. Now we're going to talk about the spinal cord, which has the alar plate, which is the dorsal, the posterior horn, and this has the sensory neurons. And the basal plate, which is the ventral anterior horn, this has the motor neurons. Now we're going to talk about the neural crest and all the things that it forms. So neural crest is the tissue that's left out when the neural tube forms. The left out neural crest cells will migrate to form the dorsal, the posterior root ganglia. The neural crest cells will also form the enteric plexi, chromaffin cells of the medulla, and the melanocytes of the skin. Neural tube defect. When does neural tube defects happen? In the third week of pregnancy, called gastrulation, specialized cell of the dorsal side of the fetus begins to fuse and form the neural tube. When the neural tube does not close completely, neural tube defects happen. Why does neural tube defects happen? Neural tube defects happen because there is a persistent connection between amniotic cavity and the spinal canal. Low levels of what vitamin is associated with neural tube defects? Before conception or during pregnancy, low levels of folic acid, also known as vitamin B9, can result in neural tube defects. What is elevated in the amniotic fluid and the maternal serum if the fetus has neural tube defects? There would be an elevated level of alpha-fetoprotein. What else is elevated in the amniotic fluid to help confirm neural tube defects? In neural tube defect, there would also be an increase in acetylcholine esterase in the amniotic fluid, and this is helpful in confirming neural tube defect. And the reason for this increase is that fetal acetylcholine esterase in the cerebrospinal fluid transudates across the defect into the amniotic fluid. Please refer to the picture on this page to help you answer the following questions. What is Spina Bifida Occulata? Spina Bifida Occulata is when there is a failure of the bony spinal canal to close. In this, there is no structural herniation, and it's usually seen in the lower vertebral levels. In this condition, the dura is still intact and is associated with a tuft of hair or skin dimple at the level of the bony defect. What is meningocele? Meningocele is when the meninges herniate through the spinal canal defect. In this, the spinal cord is not herniated, it's only the meninges that herniate through the spinal canal defect. What is meningomyelocele? Meningomyelocele is when the meninges and the spinal cord both herniate through the spinal canal defect. Forebrain anomalies. What is anencephaly? Anencephaly is the malformation of the anterior neural tube resulting in no forebrain. In this, there is an open calvarium, which causes the frog-like appearance. What are some of the clinical findings in anencephaly? The clinical findings include increase in alpha-fetoprotein. This also has polyhydramnios, and the reason for this is there's no swallowing centers in the brain, and therefore the baby is not able to swallow. This therefore will result in polyhydramnios. What is polyhydramnios? Polyhydramnios is a medical condition describing an excess amount of amniotic fluid in the amniotic sac. And this happens if the fetus is not able to swallow that amniotic fluid. It will just result in that amniotic fluid being built up in the amniotic sac. What maternal condition is associated with anencephaly? Anencephaly is associated with maternal diabetes type 1. What supplement will decrease the risk of anencephaly? Maternal folate supplement will decrease the risk of anencephaly. What is holoprosencephaly? Holoprosencephaly is the failure of the left and right hemisphere to separate, and this usually occurs during week 5 to 6. Mutation of what pathway can result in holoprosencephaly? The mutation of the sonic hedgehog signaling pathway can lead to holoprosencephaly. What does the moderate form of holoprosencephaly lead to? Moderate form of holoprosencephaly results into a cleft lip and or a cleft palate. What happens in severe form of holoprosencephaly? In severe form of holoprosencephaly results in cyclopia. Posterior fossa malformations. What are the two posterior fossa malformations? The two posterior fossa malformations are the Chiari II, also known as the Arnold-Chiari malformation, as well as the Dandy-Walker malformation. What is Arnold-Chiari malformation? Arnold-Chiari malformation is a significant cerebellar tonsillar and a Vermean herniation through the foramen magnum. In this, there is also aqueductal stenosis and hydrocephalus. This condition often presents with thoracolumbar myelomeningocele and paralysis below the defect. What is Dandy-Walker syndrome? Dandy-Walker syndrome is agenesis of the cerebellar vermis with cystic enlargement of the fourth ventricle, and this fills the enlarged posterior fossa. What are some of the conditions that Dandy-Walker syndrome is associated with? Dandy-Walker syndrome is associated with hydrocephalus and spina bifida. Syringomyelia. Briefly describe Syringomyelia from Wikipedia. Syringomyelia is a genetic term referring to the disorder in which a cyst or cavity forms within the spinal cord. This cyst, called the syrinx, can expand and elongate over time, destroying the spinal cord. The damage may result in pain, paralysis, weakness, stiffness in the back, shoulders, and extremities. Syringomyelia may also cause a loss of the ability to feel extremities of hot or cold, especially in the hands. This disorder generally leads to a cape-like loss of pain and temperature sensation along the back and arms. What is Syringomyelia? Syringomyelia is a cystic enlargement of the central canal of the spinal cord. What is the first thing to be damaged in Syringomyelia? In Syringomyelia, the crossing fibers of the spinothalamic tract are typically damaged first. What are some of the effects of Syringomyelia? Syringomyelia results in a cape-like bilateral loss of pain and temperature sensation in the upper extremities, but the fine-touch sensation is preserved. What condition is Syringomyelia associated with? Syringomyelia is associated with Chiari 1 malformation, in which there is greater than 3 to 5 mm cerebral tonsillar ectopia. What area is the syrinx generally located in Syringomyelia? In Syringomyelia, the syrinx is most commonly located between C8 to T1. Tongue development. What forms the anterior two-thirds of the tongue? The anterior two-thirds of the tongue is formed by the first brachial arch. What nerve provides the sensation to the anterior two-thirds of the tongue? The sensation to the anterior two-thirds of the tongue is provided by the mandibular nerve, which is cranial nerve V3. What nerve innervates the anterior two-thirds of the tongue that is responsible for taste? Cranial nerve 7, which is the facial nerve, is responsible for taste in the anterior two-thirds of the tongue. What forms the posterior one-third of the tongue? The posterior one-third of the nerve is formed by third and fourth arches. What nerve is mainly responsible for taste and sensation in the posterior one-third of the tongue? Taste and sensation of the posterior one-third of the tongue is mainly provided by cranial nerve 9, which is glossopharyngeal nerve. Which nerve innervates the extreme posterior part of the tongue? The extreme posterior part of the tongue is innervated by cranial nerve 10, which is the vagus nerve. Which cranial nerve is responsible for motor innervation of the tongue? Motor innervation of the tongue is by cranial nerve 12, which is the hypoglossal nerve. Where are the muscles of the tongue derived from? Muscles of the tongue are derived from the occipital myotomes. What are all the cranial nerves responsible for taste? All the cranial nerves responsible for taste includes cranial nerve 7, 9, and 10. Cranial nerve 7 is the facial nerve, cranial nerve 9 is the glossopharyngeal nerve, and cranial nerve 10 is the vagus nerve. And these three nerves are part of the solitary nucleus. What are all the cranial nerves responsible for pain sensation of the tongue? The cranial nerves that are responsible for pain sensation includes cranial nerve V3, which is the mandibular nerve, as well as cranial nerve 9 and 10, which is the glossopharyngeal nerve, and 10 is the vagus nerve. What cranial nerve is responsible for motor innervation of the tongue? Cranial nerve responsible for this is the hypoglossal nerve, or cranial nerve 12. CNS and PNS origins. What are the four things that arise from neuroectoderm? Neuroectoderm gives rise to the CNS neurons, ependymal cells, which make up the inner lining of the ventricles, which make the cerebrospinal fluid, Oligodendroglia, and Astrocytes. What two things arise from the neural crest? The neural crest gives rise to the PNS neurons and the Schwann cells. What arises from the mesoderm? Mesoderm gives rise to the microglia. What is the mnemonics to help you remember that mesoderm gives rise to microglia? The mnemonics is that microglia, like macrophages, originate from mesoderm. Neurons. What are neurons? Neurons are signal-transmitting cells of the nervous system. They are permanent cells that do not divide in adulthood, and as a general rule, have no progenitor stem cell population. Describe the physical appearance of a neuron. Neurons are signal-relaying cells with dendrites, and dendrites are where they receive input. They also have a cell body and an axon. Axons are what sends the output. What substance is used to stain the cell bodies and the dendrites? Cell bodies and dendrites can be stained with Nissl substance because this contains rough endoplasmic reticulum. The axons, on the other hand, does not have a rough endoplasmic reticulum and therefore cannot be stained with Nissl substance. What happens if an axon gets injured? If an axon gets injured, it undergoes Wallerian degeneration. What happens in Wallerian degeneration? In Wallerian degeneration, the degeneration takes place distally to the injury and axonal retraction happens proximally, and in this way it allows for a potential regeneration of an axon if the axon is of PNS. Astrocytes. Give a brief description of astrocytes from Wikipedia. Astrocytes are also known collectively as astroglia. They are characteristic star-shaped glial cells in the brain and the spinal cord. They are the most abundant cell of the human brain. They perform many functions including biochemical support of the endothelial cells that form the blood-brain barrier. They also provide nutrients to the nervous tissue. They maintain an extracellular ion balance and have a role in repair and scrapping process of the brain and spinal cord following a traumatic injury. What are astrocytes? Astrocytes are brain cells that have various functions such as physical support, repair, potassium metabolism, removal of excess neurotransmitter, and they also maintain the blood-brain barrier. One additional thing to note about astrocytes is they reactive gliosis in response to injury. What is a marker for astrocytes? The marker for astrocytes is GFAP, which stands for glial fibrillary acidic protein. Microglia. Describe microglia. Microglia are CNS phagocytes that have a mesodermal origin. They are not readily discernible in Nissl stain and have a small irregular nuclei and a relatively little cytoplasm. They are known as the scavenger cells of the CNS and respond to tissue damage by differentiating into large phagocytic cells. Describe what happens to HIV-infected microglia. HIV-infected microglia fuse to one another to form a multinucleated giant cells in the CNS. Myelin. What is myelin? Myelin is a dielectric, electrically insulating material that forms a layer, and that layer is called the myelin sheath, and this is usually around the axon of a neuron. What is the function of myelin? Myelin increases the conduction velocity of signal transmitted down the axon. This results in a saltatory conduction of action potential between nodes of Ranvier, and here there is high concentration of sodium channels. What cells provide the myelin for the central nervous system? Oligodendrocytes are what provides the myelin for the central nervous system. What cells provide the myelin for the peripheral nervous system? Schwann cells provide the myelin for the peripheral nervous system. Summarize the function of myelin. Myelin wraps and insulates the axon. This helps increase the space constant and increases the conduction velocity. Oligodendroglia. What is the function of oligodendroglia? Oligodendroglia's function is to myelinate CNS axons. Each oligodendroglia myelinates multiple CNS axons up to 50 each. How does oligodendroglia appear under Nissl stain? Under Nissl stain, they appear as small nuclei with dark chromatin and little cytoplasm. One additional note about oligodendroglia is that they are a predominant type of glial cells in the white matter. What autoimmune disease destroys the oligodendroglia? The autoimmune disease that causes a destruction in oligodendroglia is multiple sclerosis. How does oligodendroglia appear under H&E stain? Oligodendroglia looks like a fried egg on H&E stain. Schwann cells. What is the function of Schwann cells? Schwann cells' function is to myelinate axons in the peripheral nervous system. Each Schwann cell myelinates only one peripheral nervous system axon. Another function of Schwann cells is to also promote axonal regeneration. What are Schwann cells derived from? Schwann cells are derived from the neural crest. What is the benefit of myelinating an axon? The benefiting of myelinating an axon is to increase the conduction velocity via saltatory conduction between nodes of Ranvier, where there is a high concentration of the sodium channels. What condition leads to the destruction of Schwann cells? Schwann cells are destroyed in Guillain-Barré syndrome. Name a type of schwannoma that is located in the internal acoustic meatus. The type of schwannoma that is located in the internal acoustic meatus is an acoustic neuroma. What cranial nerve innervates the internal acoustic meatus? Internal acoustic meatus is innervated by cranial nerve 8, and that is the vestibulocochlear nerve. Sensory corpuscles. What are free nerve endings? Free nerve endings is an unspecialized afferent nerve ending, meaning it brings information from the body's periphery towards the brain. They function as a cutaneous receptor to detect pain. What are the two sensory fibers of the free nerve ending? The two sensory fibers of the free nerve ending are C fibers and A delta fibers. Describe the C fibers. The C fibers are slow unmyelinated fibers. Describe the A delta fiber. The A delta fibers are fast myelinated fibers. Where are the free nerve endings located? The free nerve endings are located on all skin, epidermis, and some viscera. What does the free nerve ending sense? The free nerve ending senses pain and temperature. Describe the fibers of Meissner's corpuscles, also known as tactile corpuscles. The fibers of Meissner's corpuscles, also known as tactile corpuscles, are large myelinated fibers, and they're known to adapt quickly. What is the location of Meissner's corpuscles? The location of Meissner's corpuscle is glabrous, which means hairless skin. What does the Meissner's corpuscle sense? The Meissner's corpuscle senses dynamic and fine to light touch, as well as position sense. Describe the fibers of Pacanian corpuscle. The fibers of Pacanian corpuscle are large myelinated fibers. Where are the Pacanian corpuscles located? The The Pecanian corpuscles are located deep in the skin layers. They're also located in the ligaments and joints. What does the Pecanian corpuscle sense? The Pecanian corpuscle senses vibration and pressure. Describe the fibers of Merkel's discs. The fibers of Merkel's discs are large myelinated fibers that adapt slowly. Where are the Merkel's discs located? Merkel's discs are located in the hair follicles. What does the Merkel's disc sense? The Merkel's disc senses pressure, deep static touch such as sharp objects and edges, and position senses. Peripheral nerve. What is endoneurium? Endoneurium is the inner layer of the nerve that wraps around single nerve fiber layers. In what condition would you find inflammatory infiltrate in the endoneurium? You would find inflammatory infiltrate in the endoneurium in Guillain-Barré syndrome. What is perineurium? Perineurium is the permeability barrier that surrounds a fascicle of nerve fibers. So first, individual nerve fibers are wrapped around an endoneurium. Then a group of these nerve fibers that have already been wrapped around a endoneurium goes and gets bundled up by being wrapped around a perineurium. One thing to note about perineurium is that this is the area that must be rejoined in microsurgery for limb reattachment. What is epineurium? Epineurium is a dense connective tissue that surrounds the entire nerve, which includes the fascicles and blood vessels. What does the prefix endo mean? The prefix endo means inner. What does the prefix peri mean? The prefix peri means around. What does the prefix epi mean? The prefix epi means outer. Neurotransmitters. What condition causes an increase in norepinephrine and what condition causes a decrease in norepinephrine? Norepinephrine is increased in anxiety and decreased in depression. What is the location of norepinephrine synthesis? Norepinephrine is synthesized from locus coeruleus, which is in the pons. What is the physiological response of locus coeruleus? The physiological response of locus coeruleus is in stress and panic. What condition causes an increase in dopamine? Increase in dopamine happens in schizophrenia. What condition causes a decrease in dopamine? Dopamine is decreased in Parkinson's and in depression. What is the location of dopamine synthesis? Dopamine synthesis occurs in the ventral tegmentum and in the substantia nigra, which is in the midbrain. What are some of the conditions that leads to a decrease in serotonin, also known as 5-HT? Decrease in serotonin happens in anxiety and in depression. What is the location of serotonin synthesis? Serotonin synthesis occurs in the RAF nucleus of the pons. What condition causes an increase in acetylcholine? Acetylcholine is increased in REM sleep. What conditions causes a decrease in acetylcholine? Acetylcholine is decreased in Alzheimer's and it's decreased in Huntington's. What is the location of acetylcholine synthesis? Acetylcholine is synthesized from the basal nucleus of Maynard. What are some of the conditions that leads to a decrease in GABA? Decrease in GABA occurs in anxiety and in Huntington's. What is the location of GABA synthesis? GABA is synthesized from the nucleus accumbens. What is the physiological response of nucleus accumbens and septal nucleus? Nucleus accumbens and the septal nucleus is part of the pleasure centers, and it plays an important role in reward, pleasure, addiction, and fear. Blood-brain barrier. What is the importance of the blood-brain barrier? The importance of blood-brain barrier is to prevent circulating blood substances from reaching the cerebrospinal fluid and the CNS. What are the three structures that form the blood-brain barrier? The blood-brain barrier is formed by tight junctions between non-fenestrated capillary endothelial cells, basement membrane, and astrocyte foot processes. How does glucose and amino acid cross the blood-brain barrier? Glucose and amino acid cross slowly by carrier-mediated transport mechanism. How does the nonpolar lipid-soluble substance cross the blood-brain barrier? Nonpolar lipid-soluble substance crossed rapidly via diffusion. What are some of the areas of the brain that have fenestrated capillaries and no blood-brain barrier that allows molecules in the blood to affect the brain function? The area of the brain that has fenestrated capillaries and no blood-brain barrier are area postrema that will cause vomiting after chemo, and OVLT, which is for osmotic sensing, and OVLT stands for organum vasculosum of the lamina terminalis. What is an area of the brain that has fenestrated capillaries and no blood-brain barrier, so it would allow neurosecretory products to enter the circulation? The area with fenestrated capillaries and no blood-brain barrier that will allow neurosecretory products to enter circulation is the neurohypophysis, so it allows ADH release into the blood. What are some of the other type of barriers in the body? Some of the other type of barriers in the body includes the blood-testis barrier and the maternal-fetal blood barrier of the placenta. What causes the formation of vasogenic edema? Vasogenic edema can happen if there is an infarction and/or a neoplasm that destroys endothelial cell tight junctions. What permeates the blood-brain barrier freely? Hypothalamic inputs and output permeate the blood-brain barrier. One additional important fact about the blood-brain barrier is that it helps prevent bacterial infection from spreading into the CNS, as well as it also restricts drug delivery to the brain. Hypothalamus. What are the responsibilities of the hypothalamus? The responsibilities of the hypothalamus includes thirst and water balance, adenohypophysis control. Adenohypophysis is also known as the anterior pituitary. Hypothalamus also uses the neurohypophysis, which is known as the posterior pituitary, and that releases hormones that are produced by the hypothalamus. Other responsibilities of the hypothalamus includes hunger, autonomic regulation, temperature regulation, and sexual urges. What are the two inputs received by the hypothalamus? The hypothalamus receives input from the OVLT, which stands for organum vasculosum of the lamina terminalis, as well as input from the area postrema. What is the responsibility of the OVLT? The responsibility of OVLT is to sense the changes in osmolarity. What is the responsibility of area postrema? The responsibility of area postrema is to respond to emetics. And one thing to note about OVLT and area postrema is that these two areas are not protected by the blood-brain barrier. What makes antidiuretic hormone? Antidiuretic hormone is made by the supraoptic nucleus of the hypothalamus. What makes oxytocin? Oxytocin is made by the paraventricular nucleus of the hypothalamus. Even though the ADH and oxytocin are made by the hypothalamus, where are they stored and released from? ADH and oxytocin are stored and released by the posterior pituitary, which is also known as the neurohypophysis. What is the responsibility of the lateral area of the hypothalamus? The responsibility of the lateral area of the hypothalamus is to sense hunger. What happens if there is destruction of the lateral area of the hypothalamus? In destruction of the lateral area, this will lead to anorexia and failure to thrive in infants. What inhibits hunger? Hunger is inhibited by leptin, which leads to decrease in appetite. What is a mnemonics to help you remember the destruction of the lateral area of the hypothalamus? The mnemonics to help you remember this is just remember that if you zap your lateral nucleus, you will shrink laterally. What is the responsibility of the ventromedial area? The responsibility of the ventromedial area is satiety. What happens if there is destruction of the ventromedial area? In destruction of the ventromedial area, this will lead to hyperphagia. What are some conditions that can lead to destruction of the ventromedial area? Conditions that can lead to destruction of the ventromedial area are craniopharyngiomas. What stimulates satiety and therefore decreasing appetite? Stimulation of satiety happens with leptin. What is the mnemonics that helps you remember what happens if there is destruction of the ventromedial area? The mnemonics to help you remember this is just remember that if you zap your ventromedial nucleus, you will grow ventrally and medially. What is the function of the anterior hypothalamus? The function of the anterior hypothalamus is to cool the body and also parasympathetic effects. What is the mnemonics to help you remember the function of the anterior hypothalamus? The mnemonics to help you remember this is just remember that the anterior nucleus, it leads to cooling of the body, so just remember anterior cooling, and anterior cooling stands for AC. What is the responsibility of the posterior hypothalamus? The responsibility of the posterior hypothalamus is to heat the body, and it also has sympathetic effects. What is the mnemonics to help you remember the function of the posterior hypothalamus? Just remember that posterior hypothalamus gets fired up, so it's for heating and sympathetic. So if you zap your posterior hypothalamus, you'll become poikilotherm, which means you're cold-blooded like a snake. What is the function of suprachiasmatic nucleus? The function of suprachiasmatic nucleus is the circadian rhythm. What is the mnemonics to help you remember the functions of suprachiasmatic nucleus? The mnemonics to help you remember this is just remember that you need sleep to be charismatic. So that's chiasmatic. Posterior pituitary. What is another name of posterior pituitary? Another name of posterior pituitary is neurohypophysis. What is the function of the posterior pituitary? Posterior pituitary receives hypothalamic axonal projections from the supraoptic, which makes the ADH, and the paraventricular, which makes the oxytocin. So these two things, ADH and oxytocin, are both stored and then released from the posterior pituitary. What does the word oxytocin mean? Oxytocin just means oxys, which is quick, and tokos, which means birth. So oxytocin is quick birth. What is another name of anterior pituitary? Another name for anterior pituitary is adenohypophysis. Thalamus. What is the responsibility of thalamus? The responsibility of thalamus is to be a major relay for all ascending sensory information except olfaction. Name some of the thalamic nuclei. Some of the thalamic nuclei includes VPL, which stands for the ventral posterior lateral nucleus, the VPM, which stands for the ventral posterior medial nucleus, the LGN, which stands for the lateral geniculate nucleus, the MGN, which stands for the medial geniculate nucleus, and the VL, which stands for the ventral lateral nucleus. Where does the VPL, also known as the ventral posterior lateral nucleus, gets its input information from? The input information comes from the spinothalamic and the dorsal columns, as well as medial lemniscus. What type of information is received by the VPL? The VPL receives information on pain and temperature. It also receives pressure, touch, vibration, and proprioception information. What is the end destination of the information received by the VPL? The end destination of this information is to get it to the primary somatosensory cortex. Where does the VPM, also known as the ventral posterior medial nucleus, gets its input information from? The input information for the VPM comes from the trigeminal and gustatory pathway. What type of information is received by the VPM, also known as the ventral posterior medial nucleus? The VPM receives face sensation and taste information. What is the end destination of the information received by the VPM? The end destination of the information received by the VPM is the primary somatosensory cortex. What is the mnemonics to help you remember the information that is received by the VPM? The mnemonics to help you remember this is just remember that makeup goes on the face, and VPM has that M at the end, and that stands for makeup, so makeup goes on the face. Where does the input information for the lateral geniculate nucleus come from? The input information for the LGN comes from cranial nerve 2, which is the optic nerve. What type of information is received by the lateral geniculate nucleus? The lateral geniculate nucleus from cranial nerve 2 receives vision information. What is the end destination of the information received by the lateral geniculate nucleus? The end destination of the information received by the LGN is to get it to calcarins sulcus. What is the mnemonics to help you remember the type of information that is received by the LGN? To help you remember this, just remember lateral equals light. So because it receives vision information, just remember the lateral geniculate nucleus receives information for the vision. From where does the MGN, also known as the medial geniculate nucleus, gets its input information from? The medial geniculate nucleus receives its input information from the superior olive and the inferior colliculus of tectum. What type of information is received by the MGN? The MGN receives hearing information. What is the end destination of the information received by the MGN? The end destination of the information received by the MGN goes to the auditory cortex of the temporal lobe. What is the mnemonics to help you remember the MGN receives hearing information? The mnemonics to help you remember this is just remember that medial equals music. So because medial is music and lateral is light, just remember the medial geniculate nucleus is for hearing and the lateral geniculate nucleus is for vision. Where does the input information for the ventral lateral nucleus come from? The input information for the ventral lateral nucleus, the VL, comes from the basal ganglia. What type of information comes into the ventral lateral nucleus? In the ventral lateral nucleus, motor information comes in. What is the end destination of the information received by the ventral lateral nucleus? The end destination of the information received by the VL is motor cortex. What is the limbic system? Limbic system is a collection of neural structures involved in emotion, long-term memory, olfaction, behavior modulation, and autonomic nervous system functions. What are all the structures of the limbic system? The structures of the limbic system includes the hippocampus, the amygdala, fornix, mammillary bodies, and cingulate gyrus. What are all the responsibilities of the limbic system? The responsibility of the limbic system includes feeding, fleeing, fighting, feeling, and sex. What is the mnemonics to help you remember the responsibilities of the limbic system? The mnemonics is just to remember the 5 F's. That includes feeding, fleeing, fighting, feeling, and you could just fill in the blank for the last F. Cerebellum. What are the responsibilities of cerebellum? The responsibilities of cerebellum includes to modulate movement and aids in coordination and balance. Where does the input information of the cerebellum come from? The input information of the cerebellum comes from the contralateral cortex via the middle cerebellar peduncle, and it also receives ipsilateral proprioceptive information via the inferior cerebellar peduncle from the spinal cord. Just remember the input nerves are climbing and have mossy fibers. Describe the output of information from the cerebellum. The output of information from the cerebellum happens when the cerebellum sends the information to the contralateral cortex to modulate movement. In output nerves, the Purkinje fibers send information to the deep nuclei of the cerebellum, which in turn sends information to the contralateral cortex via the superior cerebellar peduncle. What are the deep cerebellar nuclei from lateral to medial? The deep cerebellar nuclei from lateral to medial includes dentate, emboliform, globose, and fastigial. What is the mnemonics to help you remember the 4 deep cerebellar nuclei from lateral to medial? The way you remember this is just remember, don't eat greasy foods. So that's dentate, emboliform, globose, and fastigial. What is the function of the lateral cerebellum? The function of the lateral cerebellum is voluntary movements of the extremities. What happens in case of injury to the lateral cerebellum? In case of injury to the lateral cerebellum, there is propensity to fall towards the injured, so ipsilateral side. What is the responsibility of the medial cerebellum? The responsibility of the medial cerebellum is for balance and truncal coordination. Basal ganglia. What is the importance of basal ganglia? The importance of basal ganglia is in voluntary movements and making postural adjustments. How does the basal ganglia modulate movement? The basal ganglia receives cortical input and provides negative feedback to the cortex to modulate movement. What are the 2 subdivisions of the basal ganglia? The 2 subdivisions of the basal ganglia is striatum and lentiform. What makes up the striatum? The striatum is made up of putamen, which has the motor function, and caudate nucleus, which has the cognitive function. What makes up lentiform? Lentiform is made up of putamen and globus pallidus. Describe the excitatory pathway. In the excitatory pathway, there is cortical inputs that stimulate the striatum, and this leads to the release of GABA, which disinhibits the thalamus via the GPI, which is the globus pallidus internus, and the SNR, which is the substantia nigra reticulata. The end result of this is to increase motion. Now to summarize this, just remember that the cortex stimulates the striatum inhibits the SNR-GPI complex, and that SNR-GPI complex will less inhibit the thalamus. So that's disinhibition of the thalamus. Then the thalamus will stimulate the cortex cortex stimulates the muscles, and this leads to increase in motion. Describe the inhibitory pathway that decreases motion. In the inhibitory pathway, there is cortical inputs that stimulate the striatum, which disinhibits the STN, which is the subthalamic nucleus, via the GPE, which is the globus pallidus externus. Then the STN will stimulate the GPI, which is the globus pallidus internus, and the SNR, which is the substantia nigra reticulata. That then will inhibit the thalamus, and this leads to decrease in motion. Now to summarize this, just remember that the cortex stimulates the striatum will inhibit the GPE. The GPE will less inhibit the STN, so this is the disinhibition of the STN. The STN will then stimulate the SNR-GPI complex, which will inhibit the thalamus. The thalamus is then going to lessen the stimulation of the cortex, and then the cortex is going to lessen the stimulation on the muscles. So in this way, there will be a decrease in motion. What are the direct and the indirect pathways? The direct pathway is the excitatory pathway, and the indirect pathway is the inhibitory pathway. Describe how dopamine works to increase motion. The way dopamine works to increase motion is that dopamine binds to D1 receptors. This will stimulate the excitatory pathway. Dopamine also works on the D2 receptors, which will inhibit the inhibitory pathway. So if you're inhibiting the inhibition, this means there will be an increase in motion. Briefly summarize the picture on page 416. Now, to briefly summarize this picture, we've already talked about everything that's happening in this picture, but let's just quickly go over this. Now, you see on top here where it talks about dopamine, we've already just mentioned this. There's nothing new that they're talking about here because D1 and D2 receptors are both activated by dopamine. D1 receptors will stimulate the excitatory pathway, and in D2, it will inhibit the inhibitory pathway. And in both cases, there would be an increase in motion. Now, moving on from that, you see that the motor cortex has an input on the striatum based on the picture, and it has this input on, in both cases, an excitatory and an inhibitory pathway. Now, with the direct pathway, which is the excitatory pathway, you will see that there is going to be the stimulation and the release of GABA, which will disinhibit the thalamus via the GPI/SNR, and you see all of that here in the direct pathway. So this disinhibition of the thalamus will get to stimulation of the motor cortex, and this will lead to increase in motion. Now we'll talk about the inhibitory pathway or the indirect pathway. You also see the motor cortex will stimulate the striatum. This will disinhibit the STN, as you can see here, and this will be done via the GPE, which is the globus pallidus externus. And then you can also see here that the STN will go ahead and stimulate the SNR-GPI complex. This will inhibit the thalamus, and the thalamus will then go ahead and decrease the stimulation to the cortex, and the cortex will then go ahead and decrease the stimulation of the muscles, so therefore leading to decrease in the in motion. Parkinson's disease. What is Parkinson's disease? Parkinson's disease is a degenerative disorder of the CNS associated with Lewy bodies and the loss of dopaminergic neurons of the substantia nigra pars compacta. What is Lewy bodies? Lewy bodies are abnormal aggregates of protein that are composed of alpha-synuclein intracellular inclusion. What are the signs and symptoms of Parkinson's disease? The signs and symptoms of Parkinson's include tremors, which happens at rest, and they're known as the pill-rolling tremors. There's also going to be cogwheel rigidity, also akinesia or bradykinesia, and postural instability. Huntington's disease. What is Huntington's disease? Huntington's disease is an autosomal dominant trinucleotide repeat disorder. What are some of the characteristics of Huntington's disease? Huntington's disease is characterized by chorea, aggression, depression, and dementia, and sometimes it can initially be mistaken for substance abuse. How does neuronal death happen in Huntington's disease? Neuronal death can happen due to NMDAR binding and glutamate toxicity. What happens to the striatal nuclei in Huntington's disease? There could be an atrophy of the striatal nuclei, which is the main inhibitor of movement, and this can be seen on imaging. What is the trinucleotide repeat of Huntington's disease? There is expansion of the CAG repeats, which is anticipation. What is the mnemonics to help you remember the CAG repeats? The mnemonics to help you remember this is caudate loses ACH and GABA. Movement disorders. Hemiballismus. What is the presentation sign of hemiballismus? In hemiballismus, there is a sudden wild flaying of one arm plus or minus an ipsilateral leg. What is the characteristic lesion seen in hemiballismus? In hemiballismus, there is lesions of the contralateral subthalamic nucleus, which can happen in lacunar stroke. So in this condition, there is going to be half of the body that's going to be ballistic, and this is a condition that has contralateral lesions. What is the presentation sign of chorea? In chorea, the patient will have sudden, jerky, purposeless movements. What is the characteristic lesion of chorea? In chorea, there is basal ganglia lesions, and this happens in Huntington's disease. What does chorea mean? Chorea just means dancing, so it's dance-like movements. What is athetosis? Athetosis is slow writhing movements, especially seen in fingers. What characteristic lesion can lead to athetosis? Athetosis can happen in lesions of the basal ganglia that are seen in Huntington's disease. What is writhing? Writhing is just a snake-like movement. Muscle disorders. Myoclonus. What is myoclonus? Myoclonus is a sudden, brief, uncontrolled muscle contractions. Name some of the myoclonus contractions. Myoclonus contractions includes jerks and hiccups. What conditions can lead to myoclonus movements? Myoclonus movements can happen in metabolic abnormalities such as in renal and liver failure. What is dystonia? Dystonia is a sustained involuntary muscle contraction. Name a few types of dystonias. Some type of dystonias includes writer's cramp and blepharospasms, which is a sustained eyelid twitch. What are essential tremors or postural tremors? Essential tremors or postural tremors are action tremors that are exacerbated by holding posture or limb position. A thing to note about essential tremors is that it has a genetic predisposition. What is the treatment of essential tremors or postural tremors? The treatment of this is beta blockers or primidone. Patients may also sometimes self-medicate with alcohol, which will decrease the tremor amplitude.
Movement disorders. What are resting tremors? Resting tremors are uncontrolled movements of distal appendages, most noticeable in the hands. And in resting tremors, when there is a movement, intentional movement, the tremors will stop. What disease is characteristic for resting tremors? Resting tremors can happen in Parkinson's disease. What is the characteristic name given to the resting tremors of Parkinson's disease? The tremor is called pill-rolling tremor. What are intention tremor? Intention tremor is a slow zigzag motion when pointing or extending towards a target. What condition causes intention tremor? Intention tremor can happen in cerebellar dysfunction.
Cerebral cortex functions. The picture on page 418, there are two pictures. The first picture, it talks about the cerebral cortex functions. There's not much to be talked about here. You just have to kind of know some of these things here. Let's just go ahead and start talking about them. There is the frontal lobe, the parietal lobe, occipital lobe, and the temporal lobe. Now, in the frontal lobe, there's the frontal eye field, there's the premotor area, part of the extrapyramidal circuit, and the principal motor area. Now, in the parietal lobe, there's the principal sensory area. You also have, in the occipital lobe, you have the principal visual cortex. You also see here the associative auditory cortex, the Wernicke's area in this dominant hemisphere. There's also the primary auditory cortex, and you see the motor speech area, which is the Broca's area in this dominant hemisphere. Not much to talk about here without the picture, so you basically just kind of have to memorize the things by looking at the picture. Homunculus. What is homunculus? Homunculus is a topographical representation of sensory and the motor area in the cerebral cortex. It is used to localize lesions due to failure in blood supply, leading to specific defects. So for example, if there is lower extremity deficit in sensation or movement, this may indicate an involvement of the anterior cerebral artery. Name the body parts from medial to lateral based on the homunculus representation. Based on the homunculus representation from the medial to lateral, you have toes, ankles, knee, hip, trunk, shoulder, elbow, wrist, hand, little finger, ring finger, middle finger, index finger, thumb, neck, brow, eyelids and eyeball, face, then you have the lips, jaw, tongue, and swallowing. The homunculus also represents the area of vocalization, salivation, and mastication. Common brain lesions. What are the consequences of amygdala lesions bilaterally? If there is a amygdala lesion bilaterally, it can lead to Kluver-Bucy syndrome. What is Kluver-Bucy syndrome? Kluver-Bucy syndrome is a condition in which the individual will have hyperorality, which means they would talk a lot, hypersexuality, and would have disinhibited behavior. What condition can lead to amygdala lesion? Amygdala lesion can happen due to herpes simplex virus 1. What are the consequences of the frontal lobe lesion? If the frontal lobe is lesioned, it can lead to disinhibition and deficits in concentration, orientation, and judgment. With frontal lobe lesion, there can also be re-emergence of primitive reflexes. What is the consequence of right parietal lobe lesion? If there is a lesion to the right parietal lobe, it can lead to spatial neglect syndrome, in which there would be agnosia of the contralateral side of the world. So basically, you would not be able to recognize the contralateral side. Common brain lesions. What are the consequences of reticular activating system of the midbrain lesion? If the reticular activating system of the midbrain is lesioned, it would lead to reduced level of arousal and awakefulness. For example, a coma-like condition. What is a consequence of mammillary body bilateral lesion? If the mammillary bodies are bilaterally lesioned, it will lead to Wernicke-Korsakoff syndrome. What is Wernicke-Korsakoff syndrome? Wernicke-Korsakoff syndrome is a condition in which there is confusion, ophthalmoplegia, ataxia, memory loss, and this is a anterograde and retrograde amnesia, as well as confabulation and personality changes can all occur in Wernicke-Korsakoff syndrome. What is confabulation? Confabulation just means that there is an unconscious filling of gaps in one's memory by making up stuff to, fill in the gaps in the memory. What is ophthalmoplegia? Ophthalmoplegia is a condition in which there is a paralysis of muscles within the eye or surrounding the eye. What can cause mammillary body lesions? Mammillary body lesions can occur due to thiamine deficiency, which is vitamin B1, and alcohol use. This can also be precipitated by giving glucose without vitamin B1, which is thiamine, to a thiamine deficient patient. Common brain lesions. What are the consequences of basal ganglia lesion? Basal ganglia lesion can result in tremors at rest, chorea, and athetosis. What condition causes basal ganglia lesion? Basal ganglia lesion can occur due to Parkinson's disease. What are some of the consequences of cerebellar hemisphere lesion? In cerebellar hemisphere lesion, it can lead to intention tremors, limb ataxia, and loss of balance. Damages to the cerebellum results in ipsilateral deficits, so a person would fall towards the side of the lesion.
What is the mnemonic to help you remember that the cerebellar hemisphere lesion can lead to limb ataxia? The mnemonic to help you remember this is just remember that cerebellar hemispheres are laterally located and they affect the lateral limbs. What are some of the consequences of cerebellar vermis lesion? If the cerebellar vermis is lesioned, it will lead to truncal ataxia and dysarthria. What is dysarthria? Dysarthria is just difficulties articulating or difficulty speaking. What is the mnemonic to help you remember that the vermis lesion can lead to truncal ataxia? The mnemonic to help you remember this is that vermis is centrally located, so it affects the central body. So again, cerebellar hemispheres will affect the lateral limbs, and the vermis, which is central, will affect the central body, such as the truncal ataxia. What is the consequence of subthalamic nucleus lesion? If the subthalamic nucleus is lesioned, it will lead to contralateral hemiballismus, which happens in lacunar stroke. Common brain lesions. What is the consequence of hippocampus lesion? If the hippocampus is lesioned, it will lead to anterogate amnesia. In this, there would be inability to make new memories, because anterogate means going forward and retrograde means backward, so anterogate amnesia would be inability to make new memories. What is the consequence of paramedian pontine reticular formation lesion? In PPRF lesion, the eyes would look away from the side of the lesion. What is a consequence of the frontal eye fields lesion? If the lesion is located in the frontal eye fields area, it would lead to eye looking towards the lesion. Central pontine myelinolysis. What is central pontine myelinolysis? Central pontine myelinolysis is a condition in which there is acute paralysis, dysarthria, dysphagia, diplopia, and loss of consciousness. This is a condition that can cause locked-in syndrome, and in this there is massive axonal demyelination in the pontine white matter tracts. What is the cause of central pontine myelinolysis? The cause of central pontine myelinolysis is iatrogenic, which means it's physician-induced, and this is caused by overly rapid correction of the sodium levels. So when you correct hyponatremia, you do it very fast, then central pontine myelinolysis can happen. Aphasia. What is aphasia? Aphasia is a higher order inability to speak. It's a language deficit. What is dysarthria? Dysarthria is the motor inability to speak, so it's the movement deficit. Name the 4 types of aphasias. The 4 types of aphasias includes Broca's aphasia, Wernicke's aphasia, global aphasia, and conduction aphasia. What is Broca's aphasia? Broca's aphasia is a non-fluent aphasia with intact comprehension. What is the mnemonic to help you remember Broca's aphasia? The mnemonic to help you remember this is just remember Broca's broken boca, and boca means mouth in Spanish. What is another name for Broca's aphasia? Broca's aphasia is also known as expressive aphasia. What is the Broca's area? Broca's area is the inferior frontal gyrus of the frontal lobe. What is Wernicke's aphasia? Wernicke's aphasia is a fluent aphasia with impaired comprehension. What is the mnemonic to help you remember Wernicke's aphasia? The mnemonic to help you remember this is Wernicke is wordy but makes no sense. So when a person with Wernicke's talk, you're like, what? What is the Wernicke's area? Wernicke's area is the superior temporal gyrus of the temporal lobe. What is another name of Wernicke's aphasia? Another name of Wernicke's aphasia is repetitive aphasia. Summarize the difference between Broca's aphasia and Wernicke's aphasia. Broca's aphasia is when the person cannot talk properly, but they can understand. So just remember that the mouth is broken. And so this is expressive aphasia. And Wernicke's aphasia is when the person can talk properly, but they don't understand. So these people are wordy, and therefore this is repetitive aphasia. Aphasia. What is global aphasia? Global aphasia is non-fluent aphasia with impaired comprehension. So this is when they have both Broca's and Wernicke's areas that are affected. What is conduction aphasia? Conduction aphasia is poor repetition but fluent speech and intact comprehension. What causes conduction aphasia? Conduction aphasia is caused by damage to the arcuate fasciculus, so they can't repeat phrases such as no ifs, ands, or buts. Cerebral arteries, cortical distribution. What area is supplied by the anterior cerebral artery? The anterior cerebral artery supplies the anteromedial surface. What area is supplied by the middle cerebral artery? The middle cerebral artery supplies the lateral surface. What area is supplied by the posterior cerebral artery? Posterior cerebral artery supplies the posterior and the inferior surfaces. What are the two watershed zones? The watershed zones are between the anterior cerebral and the middle cerebral artery, and between posterior cerebral and middle cerebral arteries. What condition can cause a damage in the watershed zones? Damage in the watershed zones can occur in severe hypotension. What are some of the complications that can arise with damage to the watershed zone? The complications that can arise includes upper leg and upper arm weakness and defects in the higher order visual processing. Regulation of cerebral perfusion. What does brain perfusion rely on? Brain perfusion relies on tight autoregulation. What drives cerebral perfusion? Cerebral perfusion is primarily driven by PCO2. In what condition does PO2 modulate perfusion? PO2 modulates perfusion in severe hypoxia. How does therapeutic hyperventilation help in patients suffering from stroke or trauma? Hyperventilation decreases PCO2, which helps decrease the intracranial pressure in cases of acute cerebral edema, and this is done via decreasing cerebral perfusion. Describe what is happening in picture 1 of regulation of cerebral perfusion. In this first picture here, you see the normal PO2, which is at 100 arterial gas pressure, and here it will show you that hypoxemia increases cerebral perfusion pressure only when PO2 is less than 50 millimeters of mercury. So this will help you understand what we just mentioned about therapeutic hyperventilation. Since in therapeutic hyperventilation you would prevent that PO2 to drop below 50 mmHg, and therefore this will lead to decrease in cerebral perfusion and therefore a decrease in the intracranial pressure in situations such as a stroke and trauma. Describe the second picture of regulation of the cerebral perfusion. In the second picture here, you will see the normal PCO2, which is around 40 mmHg, and as the levels of CO2 increase, the perfusion pressure also increases. So just remember that the cerebral perfusion pressure is proportional to PCO2 until PCO2 reaches over 90. And after this point, even if CO2 levels are increasing, the perfusion pressure stays the same. Effects of stroke. What are all the areas of lesion if the stroke occurred at the level of middle cerebral artery? The areas of lesion would be the motor cortex, and that would have an effect on the upper limb and the face. The sensory cortex, which would also have an effect on the upper limb and face, and the temporal lobe, which can lead to Wernicke's area being affected, as well as the frontal lobe, and that can lead to Broca's area being affected. What is a symptom that can occur due to motor cortex being affected in a stroke at the level of the middle cerebral artery? Due to the effects on the motor cortex, this would lead to a contralateral paralysis of the upper limb and face. What is a symptom that can arise due to sensory cortex being affected due to a stroke at the level of the middle cerebral artery? Due to the sensory cortex being affected in this, there would be a contralateral loss of sensation in the upper limb and face. In what situation would aphasias happen in a middle cerebral artery stroke? Aphasias can occur if the lesion affects the dominant, which is usually the left hemisphere. What happens in a middle cerebral artery stroke that affects the non-dominant side? In a middle cerebral artery stroke that affects the non-dominant side, which is usually the right side, this can cause hemi-neglect. Effects of stroke, ACA or the anterior cerebral artery. What are the areas of lesion in a stroke at the level of anterior cerebral artery? Stroke at the level of anterior cerebral artery can cause motor cortex lesion, and that would affect the lower limbs, as well as sensory cortex, and that would also affect the lower limbs. What is a symptom that can arise due to motor cortex being involved in an anterior cerebral artery stroke? Due to the motor cortex being involved, this can lead to contralateral paralysis of the lower limb. What is a symptom that can arise due to sensory cortex being involved in an anterior cerebral artery stroke? The symptom that would arise would be a contralateral loss of sensation in the lower limbs. What areas are lesioned if the stroke occurs at the level of the lateral striate artery? The areas of lesion would be striatum and the internal capsule. What are the symptoms that can arise due to a stroke at the level of lateral striate artery? The symptoms that can arise in this is contralateral hemiparesis and hemiplegia. Define hemiparesis. Hemiparesis is the weakness on one side of the body. What is hemiplegia? Hemiplegia is the paralysis of one side of the body. What is the most common cause of lacunar infarct? The most common cause of lacunar infarct is hypertension. What is the second most common cause of lacunar infarct? The second most common cause of lacunar infarct is lateral striate artery stroke. Effects of strokes. What are the areas that are lesioned if the stroke is at the level of ASA, which is the anterior spinal artery? The areas that are lesioned include the lateral corticospinal tract, the medial lemniscus, and the caudal medulla, which would have an effect on the hypoglossal nerve. What is a symptom that can arise due to the lateral corticospinal tract being affected in an anterior spinal artery stroke? Due to the lateral corticospinal tract involvement, this can lead to a contralateral hemiparesis of the lower limbs. What is a symptom that can arise due to the medial lemniscus being involved in an anterior spinal artery stroke? Due to the medial lemniscus being involved, it can lead to decrease in contralateral proprioception. What is a symptom that can arise due to the caudal medulla being involved in an anterior spinal artery stroke? Due to the caudal medulla being involved, this will lead to ipsilateral hypoglossal dysfunction, so in this, the tongue would deviate ipsilaterally. One thing to note about the anterior spinal artery stroke is that the stroke would commonly be bilateral. What is the cause of medial medullary syndrome? The cause of medial medullary syndrome is infarct of the paramedian branches of the ASA and the vertebral arteries. Effects of a stroke. Posterior inferior cerebral artery. What area is lesion in a stroke at the level of posterior inferior cerebral artery? In this, the lateral medulla would be lesioned, and this would have an effect on the vestibular nuclei, the lateral spinothalamic tract, the spinal trigeminal nucleus, nucleus ambiguus, sympathetic fibers, and the inferior cerebellar peduncle. What are all the symptoms that would arise due to the lateral medulla involvement in a PICA stroke? Due to the lateral medulla involvement in a PICA, this would lead to vomiting, vertigo, nystagmus. There would also be decrease in pain and temperature sensation to the limb and face. There would also be dysphagia, hoarseness, decrease in gag reflex. There would also be ipsilateral Horner syndrome, ataxia, and dysmetria. Define nystagmus. Nystagmus is a rapid involuntary movement of the eye. What is Horner syndrome? Horner syndrome is a condition in which there is a triad of ptosis, which is drooping of the eyelids, miosis, which is constriction of the pupils, and sometimes anhidrosis. Anhidrosis is decreased sweating. Define dysmetria. Dysmetria is the inability to confirm muscle action to desired movement, and this is due to faulty judgment of distance. What is a mnemonic to help you remember some of the symptoms of posterior inferior cerebral artery stroke? The mnemonic to help you remember this is don't pick a horse that can't eat. So this will help you remember hoarseness and dysphagia. Effects of stroke. Anterior inferior cerebral artery. What are the areas that would be lesioned in a stroke at the level of anterior inferior cerebral artery? The areas that would be lesioned includes the lateral pons, which would have an involvement of the cranial nerve nuclei, vestibular nuclei, facial nucleus, spinal trigeminal nucleus, cochlear nuclei, and sympathetic fibers. In AICA stroke, there would also be a lesion of the middle and inferior cerebellar peduncle. What are the symptoms that would arise due to lateral pons involvement in AICA stroke? Due to the lateral pons being involved, there would be vomiting, vertigo, nystagmus. There would also be paralysis of the face, decrease in lacrimation, salivation, decreased taste from the anterior two-thirds of the tongue, and decrease in the corneal reflexes. On the face, there would be decrease in pain and temperature sensation. There would also be ipsilateral decrease in hearing and ipsilateral Horner's syndrome. One thing to note about AICA stroke is that it can cause lateral pontine syndrome. What is a mnemonic to help you remember AICA stroke will lead to paralysis of the face? A mnemonic to help you remember this is remember facial droop means AICA pooped. Effects of stroke. PCA, which is the posterior cerebral artery. What are the areas of lesion in a stroke at the level of posterior cerebral artery? The areas of stroke includes the occipital cortex and the visual cortex. What are some of the symptoms in a stroke at the level of posterior cerebral artery? Some of the symptoms includes contralateral hemianopia with muscular sparing. Define hemianopia. Hemianopia is blindness in one half of the visual field. Effects of stroke at the communicating arteries. One thing to note about anterior and posterior communicating arteries is that the lesions are typically aneurysms. They're not strokes, but they are saccular baryaneurysms, and they can cause impingement on the cranial nerves. What is a symptom of an aneurysm at the level of anterior communicating artery? Aneurysms at the level of anterior communicating artery will lead to visual field defects. What is a symptom of aneurysms at the level of posterior communicating artery? Due to the aneurysm at posterior communicating artery would lead to cranial nerve 3 palsy, which is the oculomotor nerve. What is observed in cranial nerve 3 palsy? In cranial nerve 3 palsy, the eye is down and out with ptosis and pupil dilation. Aneurysms. What are aneurysms? Aneurysms in general are an abnormal dilation of artery due to weakening of the vessel walls. Where does baryaneurysms occur? Baryaneurysms occur at the bifurcation in the circle of Willis. What is the most common site of baryaneurysms? The most common site is bifurcation of the anterior communicating artery. What are the complications of baryaneurysms? The complication of baryaneurysm is rupture of the aneurysm or hemorrhagic stroke. Rupture of the aneurysm is the most common complication. It leads to subarachnoid hemorrhage, and the patient complains of the worst headache of their life. How does baryaneurysms cause bitemporal hemianopia? Baryaneurysms can cause bitemporal hemianopia via compression of the optic chiasm. What are some of the conditions associated with baryaneurysms? Baryaneurysms are associated with ADPKD, which is autosomal dominant polycystic kidney disease, Ehlers-Danlos syndrome, and Marfan syndrome. What are some other risk factors of developing baryaneurysms? Other risk factors include advanced age, hypertension, smoking, and race. It's higher in blacks. What condition can lead to Charcot-Bouchard microaneurysm? Charcot-Bouchard microaneurysm is associated with chronic hypertension. Where do Charcot-Bouchard microaneurysms form? Charcot-Bouchard microaneurysms form in the small vessels such as in the basal ganglia and the thalamus. Epidural hematoma. What is the cause of epidural hematoma? Epidural hematoma happens due to rupture of the middle meningeal artery, which is the branch of the maxillary artery, and this happens secondary to the fracture of the temporal bone. So when the temporal bone gets fractured, it can rupture the middle meningeal artery, leading to epidural hematoma. Describe the lucid interval in epidural hematoma. In epidural hematoma, there is lucid interval, which just means that the patient's condition will improve a little bit before it gets worse again. And this sort of thing is seen in epidural hematoma. What are some of the complications that can arise due to epidural hematoma? Some of the complications that will arise will happen due to the rapid expansion under systemic arterial pressure, and because of this pressure, it will lead to transtentorial herniation as well as cranial nerve 3 palsy. And cranial nerve 3 is the oculomotor nerve. In this picture, you can see where the tentorium is. Now in this picture here, you see 1 through 4 showing the supratentorial herniation, and number 5 and 6 will show the infratentorial herniation. Number 1 is the uncal transtentorial herniation. Number 2 is the central herniation. Number 3 is the cingulate or the subfalcine herniation. And number 4 is the transcalvareal herniation. Number 5 is the upward cerebellar or upward transtentorial herniation. And number 6 is the tonsillar herniation.
which is the downward cerebellar herniation. Describe what the CT will look like in epidural hematoma. In epidural hematoma, the CT will show biconvex lentiform, and lentiform just means that it's like a lens, and that means it's biconvex. Hyperdense blood collection that does not cross the suture lines, but it can cross the falx and the tentorium. And here in this picture, you can see the falx cerebri. Subdural hematoma. What causes subdural hematoma? Subdural hematoma is caused by rupture of the bridging veins. The bridging veins are just small veins that are underneath the dura mater, which drain the underlying neural tissue, and they puncture the dura mater and eventually empty into the dural sinuses. So these veins, when they're ruptured, they cause subdural hematoma. Describe the formation of hematoma and subdural hematoma. In subdural hematoma, there is slow venous bleeding, so there is less pressure, and therefore the hematoma develops over time. What group of patients are more likely to suffer from subdural hematoma? Subdural hematoma can be seen in elderly individuals, alcoholics, patients with blunt trauma, and shaken baby. Predisposing factor of this is brain atrophy, shaking, and whiplash injury. Describe what is seen in a CT in a subdural hematoma. In subdural hematoma, you see crescent-shaped hemorrhage that crosses the suture line. Crescent just means like the moon when it forms that C shape. Also in subdural hematoma, due to the pressure created, there is also a midline shift, but it does not cross the falx or the tentorium. Subarachnoid hemorrhage. What is the cause of subarachnoid hemorrhage? Subarachnoid hemorrhage happens due to a rupture of an aneurysm or an AVM. AVM stands for arteriovenous malformation. Aneurysms that can rupture, such as Berry aneurysms, which are the saccular aneurysms, which happens in conditions such as Marfan's, Ehlers-Danlos, and autosomal dominant polycystic kidney disease. Describe the onset of subarachnoid hemorrhage. Subarachnoid hemorrhage has a rapid onset, and the patients complain of the worst headache of their life. Describe what is observed in a spinal tap in subarachnoid hemorrhage. You would see bloody or yellow xanthochromic spinal tap. What can occur 2 to 3 days after subarachnoid hemorrhage? 2 to 3 days after subarachnoid hemorrhage, there is a risk of vasospasm due to blood breakdown. This part is not visible on CT, and this can be treated with nimodipine. And then after this, there would be rebleed, which is visible on a CT. So vasospasm is a serious complication of subarachnoid hemorrhage because this will restrict blood flow, and this can lead to permanent brain damage. And a good way to prevent vasospasms is to do it with oral calcium channel blockers such as nimodipine. Intraparenchymal hypertensive hemorrhage. What is the cause of intraparenchymal hemorrhage? Intraparenchymal hemorrhage is most commonly caused by systemic hypertension. Other causes also includes angiopathy, vasculitis, and neoplasms. Where does the intraparenchymal hemorrhage most commonly occur? It typically occurs in basal ganglia and the internal capsule, such as in Charcot-Bouchard aneurysms of the lenticulostriate vessels, but it can also be lobar. Ischemic brain disease and stroke. When does irreversible brain damage start? Irreversible brain damage begins after 5 minutes of hypoxia. What areas of the brain are most vulnerable to hypoxia? The areas of the brain most vulnerable to hypoxia includes the hippocampus, neocortex, cerebellum, and the watershed areas. What happens after 12 to 48 hours post-ischemic brain disease? 12 to 48 hours post-ischemic brain disease, there is irreversible neuronal injury, and this leads to neurons turning red. What happens 24 to 72 hours post-ischemic brain disease? 24 to 72 hours post-ischemic brain disease, you would see necrosis and neutrophil migration. What happens 3 to 5 days post-ischemic brain disease? 3 to 5 days post-ischemic brain disease, you would see macrophages. What happens after 1 to 2 weeks post-ischemic brain disease? 1 to 2 weeks post-ischemic brain disease, you would see reactive gliosis and vascular proliferation. What happens after more than 2 weeks post-ischemic brain disease? After more than 2 weeks post-ischemic brain disease, you would see glial scar formation. Describe stroke imaging. A stroke would appear bright on diffusion-weighted MRI after 3 to 30 minutes and remains bright for 10 days. It appears dark on a non-contrast CT in about 24 hours. And if bright areas are seen on a non-contrast CT, this indicates hemorrhage. What drug is contraindicated if you see bright areas on a non-contrast CT? If you see bright areas on a non-contrast CT, this indicates hemorrhage, and therefore TPA is contraindicated.
Other causes of ischemic brain diseases. Name some other causes of ischemic brain diseases. Other causes of ischemic brain disease includes atherosclerosis, hemorrhagic stroke, ischemic stroke, and a transient ischemic attack. How does atherosclerosis lead to ischemic stroke? In atherosclerosis, there is thrombi formation which could lead to ischemic stroke with subsequent necrosis. This can form cystic cavity with reactive gliosis. What is hemorrhagic stroke? Hemorrhagic stroke is when there is intracerebral bleeding. What is the cause of hemorrhagic stroke? The cause of hemorrhagic stroke is due to hypertension, anticoagulation, and cancer, because in cancer there is abnormal vessels that can bleed. Hemorrhagic stroke can also occur secondary to ischemic stroke because after ischemia there is reperfusion. This will lead to increase in vessels fragility, and if the vessels are fragile, they can bleed out and lead to a hemorrhagic stroke. What is the cause of ischemic stroke? We already talked about this part, and that is ischemic stroke occurs due to atherosclerotic emboli, which blocks the large vessels. What is the etiology of getting an ischemic stroke due to the blockage of large vessels? The etiology includes atrial fibrillation, carotid dissection, patent foramen ovale, and endocarditis. What stroke would block the small vessels? Lacunar strokes block small vessels, and this may be secondary due to hypertension. What is the treatment of ischemic stroke? The treatment of ischemic stroke is TPA within 4.5 hours, as long as the patient presents within 3 hours of onset and there is no major risk of hemorrhage. What is transient ischemic attack, or TIA? Transient ischemic attack, or TIA, is a brief reversible episode of focal neurologic dysfunction, typically lasting less than 1 hour without acute infarction. Transient ischemic attacks are negative on an MRI, and whatever deficits may be observed in a patient are due to focal ischemia. Dural venous sinuses. What are the dural venous sinuses? Dural venous sinuses are large venous channels that run through the dura. What all drains into the dural venous sinuses? Blood from the cerebral veins and cerebrospinal fluid from the arachnoid granulation drains into the dural venous sinuses. What does the dural venous sinuses eventually drain into? The dural venous sinuses eventually drains into the internal jugular vein. Describe everything that's seen on the picture on page 425. The picture on page 425 shows the dural venous sinuses, which includes the superior sagittal sinus, which is the main location of the cerebrospinal fluid return via the arachnoid granulation. Then you also see the inferior sagittal sinus, as well as the great cerebral vein of Galen. This all drains into the straight sinus and eventually makes its way to the confluences of the sinuses. On the other end, you also see the occipital sinus. On the front of this picture, you also see the superior ophthalmic vein, the spinoparietal sinus, and the cavernous sinus. All this stuff reaches the confluences of the sinuses, eventually makes its way down to the transverse sinus, then to the sigmoid sinus, through the jugular foramen into the internal jugular vein. Ventricular system of the brain. Describe the complete fluid flow of the ventricular system. The fluid flows from the lateral ventricles to the third ventricle via the right and the left intraventricular foramina of Monro. Then the fluid goes from the third ventricle to the fourth ventricle via the cerebral aqueduct of Sylvius. Then from the fourth ventricle, the fluid goes into the subarachnoid space via the foramina of Luschka laterally and the foramen of Magendie medially. Describe the ventricular system picture here on page 426. On page 426, the ventricular system picture here shows the lateral ventricles. As you can see here, there's the anterior horn and the posterior horn. Then you could see that the lateral ventricles are connected to the third ventricle via foramen of Monro. Then you also see the cerebral aqueduct of Sylvius, which will connect to the fourth ventricle. And at the fourth ventricle, you see foramen of Luschka and the foramen of Magendie. And medially is the foramen of Magendie, and laterally you see foramen of Luschka. What makes the cerebrospinal fluid? The cerebrospinal fluid is made by the ependymal cells of the choroid plexus. Describe the reabsorption and the drainage of the cerebrospinal fluid. The cerebrospinal fluid is reabsorbed by the arachnoid granulation, and then it drains into the dural venous sinuses. Hydrocephalus. Name the 3 communicating non-obstructive hydrocephalus. The 3 communicating non-obstructive hydrocephalus includes communicating hydrocephalus, normal pressure hydrocephalus, and hydrocephalus ex vacuo. What is communicating hydrocephalus?
Communicating hydrocephalus is when there is a decrease in cerebrospinal fluid absorption by the arachnoid granulation. Because of this decrease in absorption, it leads to a buildup of cerebrospinal fluid, which leads to increase in intracranial pressure, papilledema, and herniation. And this sort of thing happens after arachnoid scarring post-meningitis. Define papilledema. Papilledema is the swelling of the optic disc, and optic disc is the area where the optic nerve enters the eyeball, and this is usually associated with increase in intraocular pressure. What is normal pressure hydrocephalus? Normal pressure hydrocephalus results from increase in subarachnoid space volume, but there is no increase in cerebrospinal fluid pressure. So basically, in normal pressure hydrocephalus, there is enlarged cerebral ventricles. And because of this expansion of the ventricles, it will distort the fibers of the corona radiata, and this leads to a clinical triad of urinary incontinence, ataxia, and cognitive dysfunction, and this is sometimes reversible. What is the mnemonic to help you remember the clinical triad of normal pressure hydrocephalus? The mnemonic to help you remember this is just remember wet, wobbly, and wacky. And this is because wet is urinary incontinence, wobbly is ataxia, and wacky is the cognitive dysfunction. What is hydrocephalus ex vacuo? Hydrocephalus ex vacuo is a condition in which there is an appearance of increase in cerebrospinal fluid, and this is because of brain atrophy. So in this, the cerebral ventricles and the subarachnoid space just looks enlarged, and this is because of the fact that the brain has atrophied. What are some of the conditions that can lead to hydrocephalus ex vacuo? Some of the conditions that can lead to this includes Alzheimer's disease, advanced HIV, and Pick's disease. So in this condition, because of the intracranial pressure being normal, the triad of normal pressure hydrocephalus is not seen here. So to simply summarize this, the apparent increase in CSF observed on imaging is actually a result of decreased neural tissue due to neuronal atrophy. What is non-communicating obstructive hydrocephalus? Non-communicating obstructive hydrocephalus is a condition caused by structural blockage of CSF circulation within the ventricular system, and this structural blockade can be caused by stenosis of the aqueduct of Sylvius. Spinal nerves. What do the 31 spinal nerves consist of? The 31 spinal nerves consist of 8 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 1 coccygeal. What is the mnemonic to help you remember the 31 spinal nerves? The mnemonic to help you remember is just remember 31, just like 31 flavors of Baskin-Robbins ice cream. What nerves exit above the corresponding vertebra? The nerves that exit above its corresponding vertebra includes nerves C1 through C7, and all of the other nerves exit below its corresponding vertebra. So for example, C3 exits above the 3rd cervical vertebra, and L2 exits below the 2nd lumbar vertebra. How does vertebral disc herniation occur? Vertebral disc herniation occurs when the nucleus pulposus, which is the soft central disc, herniates through the annulus fibrosus, which is the outer ring, and this usually occurs posterior laterally at L4 through L5 or L5 to S1. Spinal cord lower extent. How far does the spinal cord extend in an adult? In an adult, spinal cord extends to the lower border of L1 to L2 vertebrae. How far does the subarachnoid space extend in an adult? In an adult, the subarachnoid space, which contains the CSF, extends to the lower border of the S2 vertebra. What level of the vertebra is the lumbar puncture performed? The lumbar puncture is usually performed between L3 and L4, or L4 through L5, which is the level of the quada equina. What is the goal when performing the lumbar puncture? The goal when performing lumbar puncture is to obtain a sample of the cerebrospinal fluid without damaging the spinal cord. What is the mnemonic to help you remember what area to perform the lumbar puncture? The mnemonic to help you remember this is just remember to keep the cord alive, keep the spinal needle between L3 and L5. Spinal cord and associated tracts. Briefly describe the picture here on page 427. Just to briefly get oriented with the picture, we're going to look at the anterior spinal artery. On the anterior side and on the posterior side, you see the posterior spinal arteries. You also see the gray matter here, which is the darker orange part. You also see the anterior spinal thalamic tract, which is responsible for crude touch and pressure. The lateral corticospinal tract, which is for voluntary motor movements for legs and arms. You see the anterior horn and the posterior horn along with the intermediate horn. There's also the lateral spinal thalamic tract for pain and temperature. You also see the dorsal columns here, which is responsible for pressure, vibration, touch, and proprioception. The dorsal column is broken up into two different things, which includes fasciculus cunatus and fasciculus gracsalis. The fasciculus cunatus is responsible for upper body and extremities, whereas the fasciculus gracsalis is responsible for the lower body and extremities. So basically, the dorsal column is organized as you are, with hands at the side, arms outside, and legs inside. We have also included this additional picture right here for better understanding of this anatomy. Spinal tract anatomy and functions. Before we start with this, one thing to remember here is to remember that ascending tracts synapse and then cross. What is the function of medial lemniscal pathway of the dorsal column? The function of this is to transmit ascending pressure, vibration, fine touch, and proprioception to the sensory cortex. Describe the dorsal column medial lemniscal pathway. To understand the dorsal column medial lemniscal pathway, we're going to have to look at this picture first of all. And in this picture, you first see the receptor ending, and this neurons makes its way all the way up to the somatic sensory cortex. So this is the pathway. This picture is going to help us understand a little bit more. And you could see here is where it starts, and this is the tip of a finger. And here you see the sensory nerve endings. This neurons is going to make its way to the cell body in the dorsal root ganglia, which you could see right here. Then it enters the spinal cord, as you could see here. So this is the spinal cord, it's entering here. And then it ascends ipsilaterally in the dorsal column. So you could see all of that right here. It makes its first synapse at the medulla, and it's making it at either the cunate nucleus or the gracsalis nucleus. So which you could see right here. This is the cunate nucleus, and this is the gracsalis nucleus. So once it synapses there, it decussates in the medulla, which you could see here. It decussates in the medulla, and then it ascends contralaterally in the medial lemniscus, is what you could see right here. Then it makes its way to through the midbrain, and it has its second synapse at the VPL in the thalamus, so which is the ventral posterior nucleus, and it's part of the thalamus, as you can see right here. So this is where the second synapse is, and it makes its way eventually to the somatic sensory cortex. So this is how the pathway, the medial lemniscal pathway is of the dorsal column. Spinal thalamic tract. What is the functionality of the lateral spinal thalamic tract? The functionality of the lateral spinal thalamic tract is for pain and temperature. What is the functionality of the anterior spinal thalamic tract? The functionality of the anterior spinal thalamic tract is for crude touch and pressure. Describe the spinal thalamic tract. To learn about the spinal thalamic tract, we're going to look at this picture once again. This time we're going to look at the blue line instead of the red line, because the red line is for the dorsal column, the medial lemniscal pathway, which we have already talked about. So this time we're going to look at this blue line here, which is for the spinal thalamic tract. So in spinal thalamic tract, these neurons will make its way all the way up to the somatic sensory cortex. So starting off with the receptor, so these sensory nerve endings right here have A delta and C fibers. So these neurons will relay this information. So these neurons will go up to the cell body in the dorsal root ganglion, as you see here. Then it will make its way to the spinal cord at the level of, as you can see here, it's entering the spinal cord, and that's where it's going to have it. Describe the spinal thalamic tract. The spinal thalamic tract. Describe the spinal thalamic tract. To understand the spinal thalamic tract, we're going to look at this picture once again, and this time we're going to look at the blue line instead of the red line. The red line is what we have already talked about, and that was for the dorsal column, the medial lemniscal pathway. But now we're going to look at this blue line, which talks about the spinal thalamic tract. And here we're going to look at these neurons making its way all the way up to the somatic sensory cortex. So at the fingertip right here, as you can see a picture of a finger here, there is sensory nerve endings, and they would have A delta and C fibers. This will make its way to the dorsal root ganglion, as you could see right here. So this is the dorsal root ganglion cell, and then eventually this will enter the spinal cord, as you see here. So it's entering the spinal cord at this level, and it's going to have its first synapse here at the ipsilateral gray matter. So this is the level of the first synapse, and everything before this is the first order neuron. So this is the first synapse on the ipsilateral gray matter. Then the neurons are going to decussate at the anterior white commissure, which is right here. And so you see that right here. and then it will ascend contralaterally. So as we're seeing here, it's switching sides and it's ascending contralaterally. All right, so this is the second order neuron. So after the first synapse, all of this is second order neuron. Then it's going to have its second synapse, which is going to be at the level of VPL. VPL stands for the ventral posterior lateral nucleus of the thalamus. So that is right here. And then it's going to make its way to the sensory cortex. And this is the third order neuron. So this is basically the anatomy of the spinal thalamic tract. Lateral corticospinal tract. What is the function of the lateral corticospinal tract? The function of the lateral corticospinal tract is to provide descending voluntary movements of the contralateral limbs. Describe the lateral corticospinal tract pathway. To learn about the lateral corticospinal tract pathway, we have to first of all look at this picture here. In this picture, there's a lot of things going on, but this is a descending pathway. So what you're getting is there is going to be neurons going from the motor area of the cortex all the way down to the spinal cord, and from the spinal cord it becomes the lower motor neurons, and this will attach to the muscle at the neuromuscular junction. So let's talk about this. So from here is the starting of the upper motor neurons. So you have the cell body in primary motor cortex. So there is cell bodies of all sorts of different things, such as the trunk, the legs, and the arm. So you have the primary motor cortex, the cell body in primary motor cortex. This descends ipsilaterally. So as you can see here, there is ipsilateral descension, and this is going to descend ipsilaterally through the internal capsule until it finally gets down to this point, where it's gonna until it decussating at the caudal medulla. So at this point, it's gonna be the pyramidal decussation, and so as you can see, that's what's happening here. It's going down, and it's gonna then descend contralaterally. So after the decussation of the pyramids, is what's happening here. It's gonna descend contralaterally until finally it reaches its first synapse, and that synapse is going to be at the cell body of the anterior horn of the spinal cord, as you can see right here in the picture. So this is the first synapse, and so this is the first order neuron, and this is the upper motor neurons. From this point on, there is going to be lower motor neurons, and this is where the neurons leave the spinal cord. Eventually, it will synapse with muscles at the neuromuscular junction. So that is the lower motor neurons. So this is the corticospinal tract. Motor neuron lesion signs. What is weakness a sign of? Weakness is a sign of upper and lower motor neuron lesion. What is atrophy a sign of? Atrophy is a sign of lower motor neuron lesion. What is fasciculations, which are muscle twitches, a sign of? Fasciculations are sign of lower motor neuron lesion. What are increase in reflexes a sign of? Increases in reflexes are a sign of upper motor neuron lesion. What is decreases in reflexes a sign of? Decreases in reflexes are a sign of lower motor neuron lesion. What is increase in tone a sign of? Increase in tone is a sign of upper motor neuron lesion. What is decrease in tone a sign of? Decrease in tone is a sign of lower motor neuron lesion. What is a positive Babinski sign indication of? A positive Babinski sign is an indication of upper motor neuron lesion. What is spastic paralysis? Spastic paralysis is a type of paralysis in which there is loss or deficiency of motor control with involuntary spasms. What is flaccid paralysis? Flaccid paralysis is weakness or loss of muscle tone. What is spastic paralysis a sign of? Spastic paralysis is a sign of upper motor neuron lesion. What is flaccid paralysis a sign of? Flaccid paralysis is a sign of lower motor neuron lesion. What is clasp knife spasticity a sign of? Clasp knife spasticity is a sign of upper motor neuron lesion. What is the mnemonic to help you remember upper motor neuron lesions? Mnemonic to help you remember the upper motor neuron lesion is just remember that everything is up. So the tones are up, the DTRs, which are the deep tendon reflexes, are up, and the toes are up, which means positive Babinski sign. What is the mnemonic to help you remember the lower motor neuron lesion? The mnemonic to help you remember the lower motor neuron lesion is just remember that everything is lowered. So that means there is less muscle mass, there is decrease in muscle tone, there is decreases in reflexes, and downgoing tone, which means negative Babinski sign.
When is positive Babinski sign a normal thing? Positive Babinski sign is a normal thing in infants. Spinal cord lesions. What areas are affected in poliomyelitis and Wernicke-Hoffmann disease? The areas that are affected in poliomyelitis and Wernicke-Hoffmann disease is the anterior horn of the spinal cord. What are the characteristics of poliomyelitis and Wernicke-Hoffmann disease? The characteristic of poliomyelitis and Wernicke-Hoffmann disease is lower motor neuron lesions, and this is due to the destruction of the anterior horn, and this leads to faucet paralysis. What areas are affected in multiple sclerosis? The areas that are affected in multiple sclerosis are mostly white matter of the cervical region. Also in multiple sclerosis, you find random and asymmetric lesions. What are some of the characteristics of multiple sclerosis due to demyelination? Due to the demyelination effect of multiple sclerosis, the patient will suffer from scanning speech, intention tremor, and nystagmus. Spinal cord lesions, amyotrophic lateral sclerosis. What type of deficits are seen in patients suffering from amyotrophic lateral sclerosis, also known as ALS or Lou Gehrig's disease? The deficits seen in ALS includes combined upper motor neuron and lower motor neuron deficits with no sensory, cognitive, or oculomotor deficits. But in this patient, there is both upper and lower motor neuron signs. Defects in what enzyme can cause ALS? ALS can be caused by defects in superoxide dismutase 1. Describe how ALS progresses in a patient. ALS commonly presents as fasciculation with eventual atrophy. It's a condition that is progressive and it's fatal. What drug is used in the treatment of ALS? A drug that's used in the treatment of ALS is riluzole. What are the benefits of riluzole treatment? Riluzole treatment modestly increases survival by decreasing the presynaptic glutamase release. One thing to note about amyotrophic lateral sclerosis is that it's commonly known as Lou Gehrig's disease. A famous person to have Lou Gehrig's disease is Stephen Hawking, and since he's a brilliant scientist, it goes to show that it does not have cognitive effects. Spinal cord lesions. What areas are spared in a complete occlusion of anterior spinal artery? In complete occlusion of the anterior spinal artery, the areas that are spared are the dorsal columns and the Lissauer's tract. Why is the upper thoracic anterior spinal artery territory a watershed area? The upper thoracic anterior spinal artery territory is a watershed area because there is another artery that supplies this region, which is artery of Adamskiewicz, and that supplies the anterior spinal artery below the level of T8. What is a watershed area? Watershed area just basically means that this is a region of the body that receives dual blood supply. Spinal cord lesions. Tabes dorsalis. What causes tabes dorsalis? Tabes dorsalis is caused by tertiary syphilis. What happens to the spinal cord in tabes dorsalis? In tabes dorsalis, there is demyelination of the dorsal column and roots. What are the complications that arises in tabes dorsalis? The complications of tabes dorsalis includes impaired sensation and proprioception, as well as progressive sensory ataxia, and this would lead to inability to sense or feel the legs. What are other conditions associated with tabes dorsalis? Other conditions associated with tabes dorsalis includes the Charcot joints, shooting pain, Argyll-Robertson pupils, which is also known as prostitute pupil, in which there is small bilateral pupils that further constrict to accommodation but not to light. So these are pupils that accommodate but do not react to light. What is Charcot's joint? Charcot's joint is also known as neuropathic arthropathy. In this, there is progressive degeneration of weight-bearing joints, a process marked by bony destruction, bone resorption, and eventual deformity. What would examination of a patient with tabes dorsalis demonstrate? Examination of a patient with tabes dorsalis will demonstrate absence of deep tendon reflexes as well as a positive Romberg sign. What is Romberg sign? Romberg sign is swaying of the body or falling when the eyes are closed while standing with feet close together. This is one of the signs that police use to arrest somebody for driving under the influence of alcohol. Spinal cord lesions, Syringomyelia. What area of the spinal cord is damaged when the syrinx expands? When the syrinx expands, it damages the anterior white commissure of the spinal thalamic tract. So it would damage the second order neurons of the spinal thalamic tract.
and therefore would lead to a bilateral loss of pain and temperature sensation, and this all occurs usually at the level of C8 to T1. What condition is Syringomyelia seen with? Syringomyelia is seen with Chiari 1 malformation. One thing to note about Syringomyelia is that it can expand and affect other tracts. What effect does vitamin B12 or vitamin E deficiency have on the spinal cord? Vitamin B12 or vitamin E deficiency can lead to subacute combined degeneration, in which there is demyelination of the dorsal columns. Lateral corticospinal tracts are also affected, as well as the spinocerebellar tracts. What are some of the signs of vitamin B12 or vitamin E deficiency? Some of the signs of vitamin B12 or vitamin E deficiency includes ataxic gait, paresthesia, impaired position, and vibration senses. Define paresthesia. Paresthesia is an abnormal sensation, typically tingling or pricking. Poliomyelitis. What virus causes poliomyelitis? Poliomyelitis is caused by the poliovirus. How is poliomyelitis transmitted? Poliomyelitis has a fecal-oral transmission. Describe how poliomyelitis spreads to the CNS. Poliomyelitis replicates in the oropharynx and the small intestines before spreading via the bloodstream to the CNS. Where in the spinal cord does the poliovirus have its effect? Infection with poliovirus causes destruction of cells in the anterior horn of the spinal cord and therefore will lead to lower motor neuron death. What are some of the symptoms of poliomyelitis? Some of the symptoms of poliomyelitis is lower motor neuron lesions, and this includes weakness, hypotonia, flaccid paralysis, atrophy, fasciculations, hyperreflexia, and muscle atrophy. What are some of the signs of infection with poliomyelitis? Some of the signs of infection with poliomyelitis includes malaise, headache, fever, and nausea. What are some of the findings observed in the cerebrospinal fluid in poliomyelitis? Some of the findings in the cerebrospinal fluid will have increased white blood cells count with elevated levels of protein, but no change in the cerebrospinal fluid glucose. Virus can also be found in the stool and the throat. Wernicke-Hoffmann disease. What is Wernicke-Hoffmann disease? Wernicke-Hoffmann disease is a congenital degeneration of the anterior horn of the spinal cord. What is the consequence of Wernicke-Hoffmann disease? The consequence of Wernicke-Hoffmann disease would be lower motor neuron lesion, and this would lead to floppy baby with marked hypotonia and tongue fasciculations. What is the median age of death in patients diagnosed with Wernicke-Hoffmann disease? The median age of death in patients diagnosed with Wernicke-Hoffmann disease is 7 months of age. What type of inheritance is Wernicke-Hoffmann disease? Wernicke-Hoffmann disease is autosomal recessive inheritance. Friedreich's ataxia. What type of genetic disease is Friedreich's ataxia? Friedreich's ataxia is a autosomal recessive trinucleotide repeat disorder for the codon GAA in gene that encodes frataxin. What is the consequence of frataxin deficiency? Due to frataxin deficiency in Friedreich's ataxia, this leads to mitochondrial iron overload, which can cause damage to many proteins. So because of frataxin deficiency, this leads to impairment in the mitochondrial functioning. What are some of the symptoms of Friedreich's ataxia? Some of the symptoms of Friedreich's ataxia is staggering gait, frequent falling, nystagmus, dysarthria, pes cavus, hammer toes, hypertrophic cardiomyopathy, which is usually the cause of death in patients suffering from Friedreich's ataxia. Define dysarthria. Dysarthria is difficulty saying words with the muscles that help you talk, and this is due to the defects in the peripheral motor nerves. Define pes cavus. Pes cavus is a deformity of the foot characterized by an abnormally high arch and a hyperextension of the toes, which gives the foot the appearance of a claw. So pes cavus is also known as the claw foot. Define hammer toe. Hammer toe is a permanently contracted toe, which is a type of deformity, and in this, the toe is permanently bent, resembling a hammer. Describe how Friedreich's ataxia presents. Friedreich's ataxia presents in childhood with kyphoscoliosis. What is kyphoscoliosis? Kyphoscoliosis is an abnormal curvature of the spine in both coronal and sagittal plane. It is a combination of both kyphosis and scoliosis. What is the mnemonic to help you remember Friedreich's ataxia? The mnemonic to help you remember this is Friedreich is a fratastic. He is your favorite frat brother, always stumbling, staggering, and falling. Brown-Séquard syndrome. What is Brown-Séquard syndrome? Brown-Séquard syndrome is a condition in which there is a loss of sensation and motor function that is caused by lateral hemisection of the spinal cord. And hemisection just means cutting of the spinal cord. In hemisection of the spinal cord, there is going to be corticospinal tract damage. Due to the corticospinal tract damage, what are the findings seen in Brown-Séquard syndrome? In Brown-Séquard syndrome, there is going to be ipsilateral upper motor neuron signs below the level of the lesion, and this is due to the corticospinal tract damage. What are some of the findings in Brown-Séquard syndrome due to the dorsal column damage? Due to the dorsal column damage, there is going to be ipsilateral loss of tactile, vibration, proprioception senses below the level of the lesion. And tactile just means fine touch. What are some of the findings seen in Brown-Séquard syndrome due to the spinal thalamic tract being damaged? Due to the spinal thalamic tract damage in Brown-Séquard syndrome, there is going to be contralateral pain and temperature loss below the level of the lesion. What are some additional findings seen in Brown-Séquard syndrome? Additional findings of Brown-Séquard syndrome includes ipsilateral loss of all sensation at the level of the lesion, and there is going to be ipsilateral lower motor neuron signs such as flaccid paralysis at the level of the lesion. In Brown-Séquard syndrome, what can happen if the lesion occurs above T1? If the lesion occurs above T1, the patient may present with Horner's syndrome, and this is due to the damage of the sympathetic ganglion. What is Horner's syndrome? Horner's syndrome is a syndrome in which there is ptosis, which is drooping of the eyelids, and hydrosis, which is decreased sweating, and meiosis, which is constriction of the pupils. Horner's syndrome. What is Horner's syndrome? Horner's syndrome is a condition that arises when there is a problem with the sympathetic nervous system, and the symptoms that are seen includes ptosis, which is slight drooping of the eyelids due to the effects on superior tarsal muscle, and hydrosis, which is absence of sweating. Flushing can occur, which is rubor, and that means turning red, and this happens on the affected side of the face, as well as meiosis, which is pupil constriction. What are the conditions associated with Horner's syndrome? Conditions associated with Horner's syndrome is anything that causes a lesion of the spinal cord above the level of T1, such as Pankos tumor, Brown-Séquard syndrome, which is cord hemisection, and late-stage Syringomyelia. What is the mnemonic to help you remember Horner's syndrome? The mnemonic to help you remember Horner's syndrome is just remember PAM is horny, and PAM stands for P, ptosis, A is anhydrosis, and M is meiosis. Describe the picture here of Horner's syndrome. This picture here shows three neuro-oculosympathetic pathways. So start off at the hypothalamus and you go to the synapse in the lateral horn. So this is the first order neuron around the level of T1. Then from the synapse in the lateral horn, you go to the superior cervical sympathetic ganglion, which is at the level of C2. And then finally, you go from the superior cervical sympathetic ganglion to the pupil, the smooth muscles of the eyelid, the sweat glands of the forehead and face. And this is the third order neuron. So that's why this picture will help us understand that if there is any interruption anywhere in these pathways, it would lead to Horner's syndrome. So therefore, any lesion above the level of T1 in the spinal cord would lead to Horner's syndrome. Landmark dermatomes. What are dermatomes? Dermatome is an area of the skin that is mainly supplied by a single spinal nerve. What dermatome is supplied by cervical spinal nerve 2? Cervical spinal nerve 2 supplies the posterior half of the skull cap. What dermatome is supplied by cervical spinal nerve 3? Cervical spinal nerve 3 supplies the high turtleneck shirt area. What dermatome is supplied by cervical spinal nerve 4? Cervical spinal nerve 4 supplies the low collar shirt area. What dermatome is supplied by thoracic spinal nerve 4? Thoracic spinal nerve 4 supplies the area at the nipple. What dermatome is supplied by thoracic spinal nerve 7? Thoracic spinal nerve 7 supplies the area of the xiphoid process. What dermatome is supplied by thoracic spinal nerve 10? Thoracic spinal nerve 10 supplies at the area of the umbilicus, which is important for early appendicitis pain referral. What dermatome is supplied by lumbar spinal nerve 1? Lumbar spinal nerve 1 supplies the area at the inguinal ligament. What dermatome is supplied by lumbar spinal nerve 4? Lumbar spinal nerve 4 supplies the kneecaps. What dermatomes are supplied by sacral spinal nerve 2, 3, and 4? Sacral spinal nerve 2, 3, and 4 are responsible for erection and sensation of penile and anal zones. How does diaphragm and gallbladder pain get referred to the right shoulder? Diaphragm and gallbladder pain gets referred to the right shoulder via the phrenic nerve. What are some of the mnemonics to help you remember some of the landmark dermatomes? Some of the mnemonics includes T4 at the teat pore, T10 at the belly button for belly button. L1 you could look at as IL, which stands for inguinal ligament. L4 down on all fours, which would help you remember the L4 for the knees. And S2, S3, and S4 keeps the penis off the floor. Clinical reflexes. What spinal nerve initiates the biceps reflex? The biceps reflex is initiated by cervical spinal nerve 5. What spinal nerve initiates the triceps reflex? Triceps reflex is initiated by cervical spinal nerve 7. What spinal nerve initiates the patella reflex? Patella reflex is initiated by lumbar spinal nerve 4. What spinal nerve initiates the Achilles reflex? The Achilles reflex is initiated by sacral spinal nerve 1. What is Babinski sign? Babinski sign is the dorsiflexion of the big toe and fanning of the other toes. What is Babinski sign an indication of? Babinski sign is an indication of upper motor neuron lesion. When is Babinski sign a normal reflex? Babinski sign is a normal reflex in the first year of life. What is the easy way to remember all the clinical reflexes? To remember all the clinical reflexes, just count from 1 through 8 and you do it from bottom to up. So you're counting up in reflexes. So S1 and 2 was for Achilles, 3 and 4 is the patella, 5 and 6 is the biceps, and 6 and 7 is the triceps. Primitive reflexes. What are primitive reflexes? Primitive reflexes are reflexes that are present in a healthy infant, but they are absent in a neurologically intact adult. When do primitive reflexes start to disappear and why? Primitive reflexes begin to normally disappear within first year of life, and the reason they start to disappear is because these reflexes are inhibited by a mature developing frontal lobe. How can primitive reflexes start to reemerge again? Primitive reflexes reemerge in adults following a frontal lobe lesion. So, if the frontal lobe gets lesion, it will no longer have the ability to inhibit the primitive reflexes. Therefore, the primitive reflexes will start to reemerge. What is moral reflex? Moral reflex is the hang-on for life reflex, in which the infant abducts, extends limb when startled, and then draws them together. What is rooting reflex? Rooting reflex is movement of head towards one side if cheek or mouth is stroked, and this happens because the infant is seeking for the nipple. What is the sucking reflex? Sucking reflex is sucking response when roof of mouth is touched. What is the palmar reflex? Palmar reflex is curling of the fingers if palm is stroked. What is the plantar reflex? Plantar reflex is dorsiflexion of the large toe and fanning of other toes with plantar stimulation. What is the plantar reflex called in adults? Plantar reflex in adults is called the Babinski sign, which is an abnormal sign indicative of upper motor neuron lesion. What is the Galant reflex? Galant reflex is stroking along one side of the spine while newborn is in vertical suspension, which means they are face down, and this causes the lateral flexion of the lower body towards the stimulated side. Brainstem, ventral view. Describe the picture of brainstem, ventral view. In this picture, you're looking at the brain if the brain was above your head and you're to look up at the brain. Here you can see the optic chiasm, below that is the infundibulum. Next to the optic chiasm, or besides the optic chiasm, you see the anterior perforated substance. Below the infundibulum, you see the tuber cinereum. Then it's the mammillary body. You also see the crus cerebri, which is the anterior portion of the cerebral peduncle. There is also the pons, the middle cerebral peduncle, the pyramid, the pyramidal decussation, and cervical spinal nerve 1. On the right side of this picture, it also lists all the cranial nerves. Here you can see the cranial nerve 1, which is the olfactory nerve, and off that is also showing the olfactory bulb and the olfactory tract. It shows the cranial nerve 2, which is the optic nerve, also the optic tract. There is also cranial nerve 3, which is the oculomotor nerve, cranial nerve 4, which is the trochlear nerve, which arises dorsally and immediately decussates. Cranial nerve 5 is the trigeminal nerve. Then you have cranial nerve 6, which is the abducens nerve. Then is the facial nerve, which is cranial nerve 7. Then you have the cranial nerve 8, which is the vestibulocochlear nerve. Cranial nerve 9, which is the glossopharyngeal nerve. Cranial nerve 10, which is the vagus nerve. Cranial nerve 11, which is the accessory nerve. And cranial nerve 12, which is the hypoglossal nerve. What are the three cranial nerves that lie medially at the brainstem? The three cranial nerves that lie medially at the brainstem are cranial nerve 3, cranial nerve 6, and cranial nerve 12. Cranial nerve 3 is the oculomotor, cranial nerve 6 is the abducens, and cranial nerve 12 is the hypoglossal. What is the mnemonic to help you remember that these three nerves lie medially at the brainstem and are motor nerves? Remember that 3, 6, and 12, 3 times 2 is 6, 6 times 2 is 12, and these are the three cranial nerves that lie medially and are motor nerves. Brainstem dorsal view. Describe the picture of the brainstem dorsal view. In this picture you see the pineal body, you see the superior colliculi, inferior colliculi, superior cerebellar peduncles, middle cerebellar peduncles, fourth ventricle, and the medulla. What is the function of the pineal gland? The pineal gland's function is for melatonin secretion and to maintain the circadian rhythm. And circadian rhythm is for modulation of waking up and sleeping patterns. What is the function of superior colliculi? The function of superior colliculi is to receive input from the optic tract, and it serves as a relay center for movements of the eye, head, and neck in response to visual and other stimuli. So it's a conjugate vertical gaze center. What is inferior colliculi? Inferior colliculi is the principal midbrain nucleus of the auditory pathway, and it receives input from several peripheral brainstem nuclei in the auditory pathway, as well as input from the auditory cortex. So its main purpose is for auditory processing. What is Perinaud syndrome? Perinaud syndrome is the paralysis of the conjugate vertical gaze due to lesion of the superior colliculi. What condition can cause Perinaud syndrome? Perinaud syndrome can be caused by penialoma. What is the mnemonic to help you remember that the superior colliculi is for visual processing and the inferior colliculi is for auditory processing? The mnemonic to help you remember this is just remember your eyes are above your ears and the superior colliculi is for visual, is above the inferior colliculi for auditory. Cranial nerves. What is the name of cranial nerve 1? The name of cranial nerve 1 is the olfactory nerve. What is the function of cranial nerve 1? The function of cranial nerve 1 is for smell, and it's the only cranial nerve without thalamic relay to the cortex. What type of nerve is cranial nerve 1? Cranial nerve 1 is a sensory nerve. What is the name of cranial nerve 2? The name of cranial nerve 2 is the optic nerve. What is the function of cranial nerve 2? The function of cranial nerve 2 is for sight. What type of nerve is cranial nerve 2? Cranial nerve 2 is a sensory nerve. What is the name of cranial nerve 3? Cranial nerve 3 is the oculomotor nerve. What is the function of cranial nerve 3? The function of cranial nerve 3 is for eye movement since it innervates superior rectus, inferior rectus, medial rectus, and inferior oblique muscles. Its other function includes pupillary constrictions via innervation of the sphincter papillae muscle, which is the iris sphincter muscle, which has the Edinger-Westphal nucleus and muscarinic receptors. Other functions includes accommodation and eyelid opening due to its innervation on the levator palpebrae muscles. What type of nerve is cranial nerve 3? Cranial nerve 3 is a motor nerve. Cranial nerves. What is cranial nerve 4? Cranial nerve 4 is the trochlear nerve. What is the function of cranial nerve 4? The function of cranial nerve 4 is for eye movement due to its innervation on the superior oblique muscle. What type of nerve is cranial nerve 4? Cranial nerve 4 is a motor nerve. What is the name of cranial nerve 5? Cranial nerve 5 is the trigeminal nerve. What is the function of cranial nerve 5? The function of cranial nerve 5 is mastication, facial sensation due to its ophthalmic, maxillary, and mandibular divisions, as well as somatosensation from the anterior two-thirds of the tongue. What type of nerve is cranial nerve 5? Cranial nerve 5 is both sensory and motor nerve. What is the name of cranial nerve 6? Cranial nerve 6 is the abducens nerve. What is the function of cranial nerve 6? The function of cranial nerve 6 is for eye movement due to its innervation of the lateral rectus muscle. What type of nerve is cranial nerve 6? Cranial nerve 6 is a motor nerve. Cranial nerves. What is the name of cranial nerve 7? Cranial nerve 7 is the facial nerve. What are the functions of cranial nerve 7? The functions of cranial nerve 7 includes facial movement, taste from the anterior two-thirds of the tongue, lacrimation, salivation due to its innervation of the submandibular and the sublingual glands, eyelid closing due to its innervation of the orbicularis oculi, and it also innervates the stapedius muscles in the ear. One important thing to note about the facial nerve is that it courses through the parotid gland but does not innervate it. What type of nerve is facial nerve? Facial nerve is both a motor and a sensory nerve. What is the name of cranial nerve 8? Cranial nerve 8 is the vestibulocochlear nerve. What is the function of cranial nerve 8? The function of cranial nerve 8 is for hearing and balance. What type of nerve is cranial nerve 8? Cranial nerve 8 is a sensory nerve. What is the name of cranial nerve 9? Cranial nerve 9 is the glossopharyngeal nerve. What are all the functions of cranial nerve 9? The functions of cranial nerve 9 includes taste and somatosensation from the posterior one-third of the tongue, swallowing, salivation due to its innervation on the parotid gland, monitoring carotid body and sinuses through the chemo and baroreceptors, as well as to innervate the stylopharyngeus muscles, which elevates the pharynx and larynx. What type of nerve is the glossopharyngeal nerve? Glossopharyngeal nerve is both sensory and a motor nerve. Cranial nerves. What is the name of cranial nerve 10? Cranial nerve 10 is the vagus nerve. What are the functions of cranial nerve 10? The functions of cranial nerve 10 includes taste from the epiglottic region, swallowing, palate elevation, innervates the midline uvula, talking, coughing, innervates the thoracoabdominal viscera, and it monitors the aortic arch, chemo, and baroreceptors. What type of nerve is cranial nerve 10? Cranial nerve 10 is both a sensory and a motor nerve. What is the name of cranial nerve 11? Cranial nerve 11 is the accessory nerve. What are the functions of cranial nerve 11? The function of cranial nerve 11 includes head turning, shoulder shrugging, and this is due to its innervation on the sternocleidomastoid muscles as well as the trapezius muscle. What type of nerve is the accessory nerve? Accessory nerve is a motor nerve. What is the name of cranial nerve 12? Cranial nerve 12 is the hypoglossal nerve. What is the function of cranial nerve 12? The function of cranial nerve 12 is for tongue movement. What type of nerve is cranial nerve 12? Cranial nerve 12 is a motor nerve. Cranial nerve mnemonics. What is a mnemonic to help you remember the cranial nerves? The mnemonic to help you remember the cranial nerves is just to remember ooh, 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 to touch and feel a virgin girl's vagina and hymen. So the three oohs are for olfactory, optic, and oculomotor. 2 is for trochlear, touch is for trigeminal, and is for abducens, feel is for facial, virgin is for vestibulocochlear nerve, girl is for the glossopharyngeal nerve, vagina is for the vagus nerve, and is for the accessory nerve, and hymen for the hypoglossal nerve. What is the mnemonic to help you remember what type of nerves are the cranial nerves? The mnemonic to help you remember this is just remember, some say marry money, but my brother says big brains matter most. So some is for sensory, say is for sensory, marry is for motor, money is for motor, but is for both, my is for motor, brother is for both, says is for sensory, big is for both, brains is for both, matter is for motor, most is motor. Cranial nerve nuclei. Where are the cranial nerve nuclei located? The cranial nerve nuclei are located in the tegmentum portion of the brainstem, which is between dorsal and the ventral portions. What are the cranial nerves that have their nuclei in the midbrain? The cranial nerves with nuclei in the midbrain includes cranial nerve 3 and cranial nerve 4, which are the oculomotor nerve and the trochlear nerve. What cranial nerves have their nuclei located in the pons? The cranial nerves with nuclei located in the pons includes cranial nerve 5, cranial nerve 6, cranial nerve 7, and cranial nerve 8, which are the trigeminal nerve, the abducens nerve, the facial nerve, and the vestibulocochlear nerve. What are the cranial nerves with their nuclei located in the medulla? The cranial nerves with their nuclei located in the medulla includes cranial nerve 9, cranial nerve 10, and cranial nerve 12. What cranial nerve has its nuclei in the spinal cord? The cranial nerves to have its nuclei in the spinal cord is cranial nerve 11, which is the accessory nerve. What separates the cranial nerve motor nuclei from the cranial nerve sensory nuclei? Sulcus limitans is what separates the cranial nerve motor nuclei, which is located medially, from the sensory nuclei, which is located laterally. From which part of the embryonic nervous system does the lateral nuclei or the sensory nuclei arise from? The lateral nuclei, which is the sensory nuclei, arises from the alar plate. From which part of the embryonic nervous system does the medial nuclei, which is the motor nuclei, arise from? The medial nuclei or the motor nuclei arises from the basal plate. Cranial nerve reflexes. Before we talk about different types of cranial nerve reflexes, let's just talk about what a reflex is and what afferent and efferent means in terms of cranial nerve reflexes. So a reflex is a series of physiological steps that occur rapidly to produce a reflex. So let's just use gag reflex as an example. So in gag reflex, there is going to be an object that reaches the nerve in the back of the throat, and that sends a message via the afferent nerves, and this goes to the central nervous system. So afferent nerves brings in the information to the central nervous system. CNS receives this information and it sends a appropriate response via an efferent nerve, and these are the motor nerves, which will create a physical response. So that's what afferent and efferent means in terms of cranial nerve reflexes. What is the afferent nerve that helps cause the corneal reflex? The afferent nerve which helps cause the corneal reflex is the ophthalmic nerve, which is the first branch of the trigeminal nerve, also known as the nasociliary branch. What is the efferent nerve that helps cause the corneal reflex? The efferent nerve that helps cause the corneal reflex is the temporal branch of facial nerve, which has innervation on the orbicularis oculi. What is the afferent nerve that helps cause lacrimation reflex? The afferent nerve that helps cause lacrimation reflex is the ophthalmic nerve, which is the first branch of the trigeminal nerve. One thing to note about this is that even if there is a loss of reflex, that does not mean that emotional tears will not happen. So in learning this, it's important to differentiate the difference between emotional tears and lacrimation reflex. What is the efferent nerve that helps cause lacrimation reflex? The efferent nerve that helps cause lacrimation reflex is cranial nerve 7, which is the facial nerve. What is the afferent nerve that helps cause jaw jerk reflex? The afferent nerve that helps cause the jaw jerk reflex is the sensory mandibular nerve, which is the third branch of the trigeminal nerve. What is the efferent nerve that helps cause the jaw jerk reflex? The efferent nerve that helps cause the jaw jerk reflex is the motor mandibular nerve, which is the third branch of the trigeminal nerve. What is the afferent nerve that helps cause the pupillary reflex? The afferent nerve that helps cause the pupillary reflex is cranial nerve 2, which is the optic nerve. What is the efferent nerve that helps cause the pupillary reflex? The efferent nerve that helps cause the pupillary reflex is the oculomotor nerve. What is the afferent nerve that helps cause the gag reflex? The afferent nerve that helps cause the gag reflex is cranial nerve 9, which is the glossopharyngeal nerve. What is the efferent nerve that helps cause the gag reflex? The efferent nerve that helps cause the gag reflex is cranial nerve 10, which is the vagus nerve. Vagal nuclei. What is nucleus solitarius? Nucleus solitarius is a series of nuclei forming a vertical column of gray matter embedded in the medulla oblongata. What is the function of nucleus solitarius? The function of nucleus solitarius is to receive visceral sensory information such as taste, baroreceptor, and gut distension. What cranial nerves provide input to the nucleus solitarius? The cranial nerves that provide input to the nucleus solitarius includes cranial nerve 7, 9, and 10. Cranial nerve 7 is the facial nerve, cranial nerve 9 is the glossopharyngeal nerve, and cranial nerve 10 is the vagus nerve. What is the function of nucleus ambiguus? The function of nucleus ambiguus is to provide motor innervation of pharynx, larynx, and the upper esophagus for swallowing and palate elevation. What cranial nerves provide input to the nucleus ambiguus? The cranial nerves that provide input to the nucleus ambiguus includes cranial nerve 9 and cranial nerve 10, so that's glossopharyngeal nerve and the vagus nerve. What is the function of the dorsal motor nucleus? The function of dorsal motor nucleus is to send autonomic parasympathetic fibers to the heart, lungs, and the upper GI. What cranial nerves provides input to the dorsal motor nucleus? The cranial nerve that provides input to the dorsal motor nucleus is cranial nerve 10, which is the vagus nerve. What is the mnemonic to help you remember that nucleus solitarius is for sensory information and nucleus ambiguus is for motor innervation? The mnemonic to help you remember this is remember that nucleus solitarius has that S for solitarius and S for sensory, whereas nucleus ambiguus has M in it, and that's for motor innervation. Cranial nerve and vessel pathways. What cranial nerve passes through the small perforated foramina of the cribriform plate? The cranial nerve that passes through the foramina of the cribriform plate is the olfactory nerve, cranial nerve 1. What cranial nerves pass at the level of the middle cranial fossa through the sphenoid bone? Cranial nerves 2 to 6 pass through this area. What cranial nerve and vessels passes through the optic canal? Cranial nerve 2, ophthalmic artery, and the central retinal vein passes through the optic canal. What cranial nerves and vessels passes through the superior orbital fissure? Cranial nerve 3, cranial nerve 4, cranial nerve 5-1, cranial nerve 6, ophthalmic vein, and sympathetic fibers passes through the superior orbital fissure. What passes through the foramen rotundum? Cranial nerve V2 passes through the foramen rotundum, and cranial nerve V2 is the maxillary nerve. What nerve passes through foramen ovale? Cranial nerve V3 passes through foramen ovale, and cranial nerve V3 is the mandibular nerve. What artery passes through the foramen spinosum? Middle meningeal artery passes through the foramen spinosum. What are all the cranial nerves that pass through the posterior cranial fossa through the temporal or the occipital bone? The cranial nerves that pass through the posterior cranial fossa through temporal or the occipital bone is cranial nerve 7 through 12. What cranial nerve passes through the internal auditory meatus? The cranial nerves that pass through the internal auditory meatus includes cranial nerves 7 and 8. What cranial nerves and vessels pass through the jugular foramen? Cranial nerves and vessels that pass through the jugular foramen includes cranial nerve 9, 10, and 11, as well as the jugular vein. What cranial nerve passes through the hypoglossal canal? Cranial nerve 12 passes through the hypoglossal canal, which is the hypoglossal nerve. What all passes through the foramen magnum? Spinal roots of cranial nerve 11, brainstem, and vertebral arteries passes through the foramen magnum. What is the mnemonic to help you remember that the 3 divisions of cranial nerve 5 exit at different locations? The mnemonic to help you remember this is just remember division of cranial nerve 5 exit owing to standing room only. S is for superior orbital fissure, from which the ophthalmic nerve passes. R is for foramen rotundum, from which the maxillary nerve passes, and only is for foramen ovale, from which the mandibular nerve passes. Cavernous sinus. What is the cavernous sinus? Cavernous sinus is a collection of venous sinuses on either side of the pituitary. Describe the drainage through the cavernous sinus. Blood from the eye and the superficial cortex drains into the cavernous sinus and then eventually makes its way into the internal jugular vein. Name the nerves and vessels that pass through the cavernous sinus on its way to the orbit. The nerves and vessels that pass through the cavernous sinus on its way to the orbit includes cranial nerve 3, which is the oculomotor nerve, cranial nerve 4, which is the trochlear nerve, cranial nerve 5-1, which is the ophthalmic nerve, cranial nerve 5-2, which is the maxillary nerve, cranial nerve 6, which is the abducens nerve, postganglionic sympathetic fibers, as well as the cavernous portion of the internal carotid artery. All these pass through the cavernous sinus en route to the orbit. One thing to note is cranial nerve 5-1 and 5-2 are the only 2 things that pass through the cavernous sinus because they help in controlling the extraocular muscles. Cranial nerve 5-3 does not pass through here because it does not control extraocular muscles. Describe the picture here of the cavernous sinus. In the picture here, we'll first of all start where it says the optic chiasm, so that's the picture of the optic chiasm. Right below that you see the hypophysis, which is the pituitary gland, and on either sides of this you have the cavernous sinus, which is all that blue stuff that you see here. Here we see 2 internal carotid arteries, and one of them is the cavernous portion of the internal carotid artery, and one is not. So you can see both of that here. There is also the anterior clinoid process. You see the oculomotor nerve here, which is cranial nerve 3. You see trochlear nerve, which is cranial nerve 4, ophthalmic nerve, which is cranial nerve 5-1, maxillary nerve, which is cranial nerve 5-2, abducens nerve, which is cranial nerve 6, and it also shows the dura, the arachnoid, and the pia mater. What is cavernous sinus syndrome? Cavernous sinus syndrome is a condition that occurs due to mass effect, and that mass effect happens if there is any sort of tumor of the hypophysis. So if there is a pituitary adenoma, these tumors can get large in size, and due to that, it will create a mass effect due to the size of the tumor, and that can cause compression of nearby nerves, and that would lead to ophthalmoplegia and decrease in corneal and maxillary sensation with normal vision. Define ophthalmoplegia. Ophthalmoplegia is paralysis of the muscles within or surrounding the eye. Common cranial nerve lesions. What is a consequence of cranial nerve 5 motor lesion? A consequence of cranial nerve 5 motor lesion would be jaw would deviate towards the side of lesion due to unopposed force from the opposite pterygoid muscle. What is a consequence of cranial nerve 10 lesion? In cranial nerve 10 lesion, the uvula deviates away from the side of lesion, and the reason this happens is because the weak side collapses and the uvula points away. What is a consequence of cranial nerve 11 lesion? In cranial nerve 11 lesion, there is going to be weakness in turning head to the contralateral side of the lesion due to weakness in the sternocleidomastoid muscle. And in this, the shoulders will also droop on the side of the lesion due to the weakness of the trapezius muscle. One thing to note about the sternocleidomastoid muscles is that the left sternocleidomastoid contracts to help turn the head to the right. What is the consequence of cranial nerve 12 lesion? In cranial nerve 12 lesion, there is going to be lower motor neuron lesion, and in this, the tongue would deviate towards the side of the lesion. And the reason this happens is due to the weakened tongue muscles on the affected side. What is the mnemonic to help you remember cranial nerve 12 lesion? To remember the cranial nerve 12 lesion, you just remember to lick your wounds. So basically, the tongue is going to deviate towards the side of the lesion. So cranial nerve 5 is towards, cranial nerve 10 is away, cranial nerve 11 is contralateral, and 12 is towards. Hearing loss. Name the 3 types of hearing loss. The 3 types of hearing loss are conductive, sensorineural, and noise-induced. What is a Rini test? Rini test is a hearing test that compares perception of sound transmitted by air conduction versus bone conduction. This test is done using a tuning fork, and you vibrate the tuning fork and you place it next to the ear, and then you also vibrate the tuning fork and place it on the mastoid. If the air conduction is longer than the bone conduction, this is a normal situation. But if the bone conduction is longer than the air conduction, then this is abnormal and is suggestive of conductive hearing loss. What is the Weber test? Weber test is a hearing test that also uses the tuning fork. You vibrate the tuning fork and place it in the middle of the head, and you ask the patient on which ear do they hear better. In a normal situation, they should hear equally on both ears, but if the sound in one ear is better than the other, that means the ear with a better sound is the affected ear. What are the Rini test results and Weber test results in conductive hearing loss? In conductive hearing loss, there is going to be abnormal Rini test because in conductive hearing loss, the bone conduction at the mastoid process is going to be greater than the air conduction. In conductive hearing loss for Weber test, the sound is going to be heard better in the affected ear. Describe the Rini test and the Weber test results in sensorineural hearing loss. In sensorineural hearing loss, the Rini test is going to be normal because air conduction is going to be greater than the bone conduction, and the air conduction is checked when you put the tuning fork right next to the ear. And the Weber test result in sensorineural hearing loss will show that the sound is heard better in the unaffected ear. So the sound is heard better in the normal ear. In sensorineural hearing loss, even though the Rini test is normal, because air conduction is greater than bone conduction, and the reason it seems normal is because both air and bone conduction are decreased equally. So since both are decreased equally, the difference between them is unchanged. How does noise-induced hearing loss happen? Noise-induced hearing loss can happen due to the damage of the stereociliated cells and organ of Corti, and it can also happen if there is sudden extremely loud noises which can cause the tympanic membrane to rupture. In noise-induced hearing loss, what frequency hearing is lost first? In noise-induced hearing loss, the high-frequency hearing is lost first. Facial lesions. Describe the upper motor neuron facial lesion. Upper motor neuron facial lesion is when the lesion occurs at the motor cortex or the connection between cortex and the facial nucleus. What is the upper motor neuron lesion of the facial nerve called? The upper motor neuron lesion of the facial nerve is called the central facial palsy. What are the consequences of central facial palsy? The consequence of central facial palsy is contralateral paralysis of the lower face. But in this situation, the forehead is spared due to the fact that there is bilateral upper motor neuron innervation. What is the lower motor neuron lesion of the facial nerve called? The lower motor neuron lesion of the facial nerve is called facial nerve palsy. What is the consequence of facial nerve palsy? The consequence of facial nerve palsy is ipsilateral paralysis of upper and lower face. What is facial nerve palsy? Facial nerve palsy is a complete destruction of the facial nucleus itself or its branchial efferent fibers, like the facial nerve proper. What is the clinical presentation seen with facial nerve palsy? The clinical presentation of facial nerve palsy is peripheral ipsilateral facial paralysis with inability to close eye on the involved side, and this condition can occur idiopathically, and there is gradual recovery in most cases. Name some conditions that can lead to complication of facial nerve palsy. Facial nerve palsy is seen as a complication in AIDS, Lyme disease, herpes simplex, herpes zoster, sarcoidosis, tumors, and diabetes. What is facial nerve palsy called if the onset is idiopathic? If the onset of facial nerve palsy is idiopathic, it's called Bell's palsy. Briefly, describe what's happening in the picture of facial lesion. This picture here shows the facial nerve and where it goes and how it innervates the face. So we're going to first start off talking about it from where it says the face area of the motor cortex. Now from this, there you also see the cortical bulbar tract, and if the lesion occurs at this level where you see the first black line, the solid black line, so if the lesion occurs here, because the lesion is occurring before the facial nucleus, so if the lesion is at this level, it's called the upper motor neuron lesion, and this is the central facial palsy. Then you also see the facial nucleus, which has the upper and the lower division, and right underneath that you see the lower motor neuron lesion. So if the lesion occurs at this level, it's the lower motor neuron lesion, and this is called facial nerve palsy. Mastication muscles. What are the three muscles that closes the jaw? The three muscles that closes the jaw is the masseter, temporalis, and the medial pterygoid. What is the mnemonic to help you remember the three muscles that closes the jaw? The mnemonic to remember this is M for munch, which is the masseter, and then temporalis has an M in it, and the medial pterygoid. Name the muscle that opens the jaw. The one muscle that opens the jaw is the lateral pterygoid. What is the mnemonic to help you remember that the lateral pterygoid opens the jaw? The mnemonic to help you remember this is just remember lateral lowers, which means that lateral lowers the jaw. So it does take more muscles to keep your mouth shut. What nerve innervates all the mastication muscles? The nerve that innervates all the mastication muscle is the third branch of the trigeminal nerve, which is the mandibular nerve. Eye and retina. Briefly describe the anatomy of eye and retina by looking at the picture. In the picture here, you see the eye and retina. We're going to start off looking at where it says cranial nerve 2, which is the optic nerve entering the eyeball. And here you also see in between the optic nerve, you see the central retinal artery and the central retinal vein. Along with that, you also see the hyaloid canal. There is also the optic disc and the fovea centralis. You also see the different layers of the eyeball, and the three layers are retina, choroid, and the sclera. You also see the ora serrata and the vitreous chamber, which is part of the posterior segment of the eye. And the anterior segment of the eye is made up of the anterior chamber and the posterior chamber. Now we're going to look at where it says the ciliary muscle and the ciliary process. These two things collectively makes up the ciliary body. You also see the zonular fibers along with limbus, the Schlemm canal, lens, capsule of lens, iris, cornea, pupil, and lastly the two pupillae, which are the sphincter pupillae and the dilator pupillae. So this was briefly the anatomy of the eye and retina. Common eye conditions, refractive errors. What are refractive errors? Refractive errors of the eye are impaired vision that improves with glasses. Name the 5 refractive errors. The 5 refractive errors is hyperopia, myopia, astigmatism, accommodation, and presbyopia. What is hyperopia? Hyperopia is when the eye is too short for refractive power of cornea and the lens. What is the consequence of hyperopia? The consequence of hyperopia is that the light focuses behind the retina. What is myopia? Myopia is when the eye is too long for refractive power of cornea and lens. What is the consequence of myopia? The consequence of myopia is that the light is then going to focus in front of the retina. What is astigmatism? Astigmatism is abnormal curvature of the cornea, and this results in different refractive power at different axes. Describe the process of accommodation. The process of accommodation is when you're trying to focus on a near object, and in this, the ciliary muscle tightens, the zonular fibers relaxes, the lens becomes more convex, and you're able to focus and accommodate on nearby objects. The accommodation of the eye is done with convergence and meiosis. What is presbyopia? Presbyopia is decreased change in focusing ability during accommodation due to sclerosis and decreased elasticity. What is uveitis? Uveitis is inflammation of the uveal coat, which consists of the iris, ciliary body, and the choroid. What are the causes of uveitis? Uveitis is often associated with systemic inflammatory disorder like sarcoid or sarcoidosis, rheumatoid arthritis, juvenile idiopathic arthritis, TB, and HLA-B27 associated conditions. What is retinitis? Retinitis is the inflammation of the retina that causes retinal edema and necrosis leading to a scar. What are the causes of retinitis? The causes of retinitis are usually viral associated, like cytomegalovirus, herpes simplex virus, and herpes zoster virus. Retinitis can also be due to immunosuppression. What is central retinal artery occlusion? Central retinal artery occlusion is a disease of the eye where the blood flow through the central retinal artery is blocked. There are several causes of this, but the most common is carotid artery atherosclerosis. What is the consequence of central retinal artery occlusion? The consequence of central retinal artery occlusion is acute, painless monocular vision loss. What is the clinical presentation of central retinal artery occlusion? The clinical presentation of central retinal artery occlusion is that there will be retinal whitening with cherry red spot. Describe the aqueous humor pathway. Before we start talking about the aqueous humor pathway, let's first of all look at the anatomy here. First of all, we see the sclera, the cornea, the canal of Schlemm, the trabecular meshwork, the iris, the dilator pupillae, the sphincter pupillae, the anterior chamber, the posterior chamber, the lens, the ciliary epithelium, and the ciliary muscle. Now, as you can see here, that the ciliary epithelium is what produces the aqueous humor, and this aqueous humor is located in the anterior and posterior chambers of the eye. And this aqueous humor that's produced has a lot of different functions, such as maintaining the intraocular pressure, along with providing nutrients and a lot of other things. The trabecular meshwork collects the aqueous humor that flows through the anterior chamber, and then the canal of Schlemm collects the aqueous humor from the trabecular meshwork. What is glaucoma? Glaucoma is optic neuropathy, usually with increased intraocular pressure. What is open or wide-angle glaucoma? Open or wide-angle glaucoma is characterized by peripheral, then central vision loss, usually with increased intraocular pressure. So the loss of vision first happens in the peripheral and then in the central. What are the classic clinical presentation of open wide-angle glaucoma? The classic clinical presentation of open wide-angle glaucoma is optic disc atrophy with cupping associated with increased age, African American race, family history, and increase in intraocular pressure. This condition is painless and it's more common in the US. What are the primary and secondary causes of open wide-angle glaucoma? The primary cause of open wide-angle glaucoma is unclear, but the secondary causes include uveitis, trauma, corticosteroids, and vasoproliferative retinopathy that can block or decrease outflow at the trabecular meshwork. Describe the process in how closed or narrow-angle glaucoma happens. The way closed or narrow-angle glaucoma happens is first, if there is an enlargement or forward movement of the lens against the central iris, this will lead to obstruction of the normal aqueous flow through the pupil. So then if the aqueous flow is blocked at this level, this will cause the fluid buildup behind the iris, and this fluid buildup behind the iris pushes peripheral iris against the cornea, and this blocks the aqueous humor flow through the trabecular meshwork, and this is how closed or narrow-angle glaucoma happens. What is chronic angle closure glaucoma? Chronic angle closure glaucoma is a type of glaucoma that's often asymptomatic, and it happens with damage to the optic nerve and peripheral vision. What condition is referred to as true ophthalmic emergency? Acute angle closure glaucoma is what is considered to be true ophthalmic emergency. Describe how acute angle closure glaucoma happens. The way acute angle closure glaucoma happens is when there is increase in intraocular pressure. This pushes the iris forward, and this will close the angle abruptly. Describe the classic clinical presentation of acute angle closure glaucoma. The classic clinical presentation of acute angle closure glaucoma is that it's a condition which is very painful with sudden vision loss, halos around light, rock-hard eye, and frontal headaches are all going to be complaints seen in acute angle closure glaucoma. What is a drug that you would avoid in acute angle closure glaucoma? A drug not to give in acute angle closure glaucoma is epinephrine, and the reason for this is because it has mydriatic effects. And mydriatic just means a drug that causes the pupil of the eyes to dilate. What is cataract? Cataract is painless, often bilateral opacification of the lens, and this leads to decrease in vision. What are all the risk factors of getting cataracts? The risk factors of getting cataracts are age, smoking, alcohol use, excessive sunlight, prolonged corticosteroid use, classic galactosemia, galactokinase deficiency, diabetes, trauma, and infections. What is papilledema? Papilledema is optic disc swelling, and this usually happens bilaterally, and this happens due to increase in intraocular pressure. And papilledema can also happen secondary to mass effect. What is observed in a fundoscopic exam of papilledema? In a fundoscopic exam, you would see enlarged blind spot and elevated optic disc with blurred margins. Extraocular muscles and nerves. Describe the picture of extraocular muscle and nerves. The picture of extraocular muscles and nerves shows the superior rectus muscle, which is innervated by cranial nerve 3, that's the oculomotor nerve. Then you also see the superior oblique muscle that is innervated by cranial nerve 4, which is the trochlear nerve. Then you see the medial rectus muscle, which is innervated by cranial nerve 3, the oculomotor nerve. Inferior rectus muscle, innervated by cranial nerve 3, the oculomotor nerve. The inferior oblique muscle, also innervated by cranial nerve 3, the oculomotor nerve. And the lateral rectus muscle, which is innervated by cranial nerve 6, which is the abducens nerve. What are the mnemonics to help you remember the extraocular muscle and nerves? The mnemonic to help you remember this is just remember cranial nerve 6 innervates the lateral rectus. Cranial nerve 4 innervates the superior oblique. Cranial nerve 3 innervates the rest. So the chemical formula of this becomes Lr6SO4R3. What are all the function of superior oblique muscle? The function of superior oblique muscle is to abduct, intowards, and depresses while adducts. What is the clinical presentation of cranial nerve 3 damage? In cranial nerve 3 damage, the eye looks down and out, along with ptosis, pupillary dilation, and loss of accommodation. What is ptosis? Ptosis is the drooping or falling of the upper eyelids. What is the classic clinical presentation of cranial nerve 4 damage? The clinical presentation of cranial nerve 4 damage is the eye moves upward, particularly with contralateral gaze and ipsilateral head tilt. So with this condition, you would have problems going downstairs because when you look down, the eye is going to move upward. What are the classic clinical presentations seen with cranial nerve 6 damage? The classic clinical presentation of cranial nerve 6 damage is medially directed eye that cannot abduct. Testing extraocular muscle. Describe the direction a patient has to look in order to test the function of the superior oblique. To test the function of the superior oblique, the patient has to depress their eye from adducted position, so basically they have to look down and in towards the nasal. What direction does the patient need to look in order to test the function of the medial rectus? To test the function of the medial rectus, the patient has to look medially towards the nasal. What direction does the patient need to look to test the function of the inferior oblique? To test the function of the inferior oblique, the patient has to look up and towards the nasal. What direction does the patient need to look to test the function of the superior rectus? To test the function of the superior rectus, the patient has to look up and out, so towards the temporal. What direction does the patient need to look to test the function of lateral rectus? The direction a patient needs to look to test the function of lateral rectus is laterally towards the temporal. What direction does a patient need to look to test the function of the inferior rectus? To test the function of inferior rectus, the patient has to look down and out towards the temporal. What is the mnemonic to help you remember that in inferior oblique you have to look up? The mnemonic to help you remember is just remember IOU. And IOU would be inferior oblique up. What is the mnemonic to help you remember that oblique muscles move the eye in opposite direction? Just remember, oblique equals opposite. Pupillary control. What is meiosis? Meiosis is pupillary constriction. Which autonomic nervous system is responsible for meiosis? Parasympathetic nervous system is responsible for meiosis. For the following questions, please refer to the picture of pupillary light reflex. What is the first order neuron for meiosis? The first order neuron is at the Edinger-Westphal nucleus to the ciliary ganglion via cranial nerve 3, which is the oculomotor nerve. What is the second order neuron for meiosis? The second order neurons are the short ciliary nerves that go to the pupillary sphincter muscle. What is mydriasis? Mydriasis is the dilation of the pupils. Which autonomic nervous system controls mydriasis? Mydriasis is controlled by the sympathetic nervous system. Describe the first order neuron for mydriasis. The first order neuron goes from the hypothalamus to the ciliospinal center of Budge at the level of C8 to T2. Describe the route of second order neuron for mydriasis. The second order neuron exits at the level of T1 and it travels along the cervical sympathetic chain near the lung apex and the subclavian vessels and eventually makes its way to the superior cervical ganglion. Describe the route of third order neuron for mydriasis. The route of third order neuron for mydriasis is from the superior cervical ganglion. It then goes through the carotid plexus and then through the cavernous sinus and eventually enters the orbit as the long ciliary nerve to the pupillary dilator muscles. Pupillary light reflex. Please follow the picture of pupillary light reflex to answer the following questions. Describe the pupillary light reflex. When you shine the light in either of the eye, the light hits the retina and a signal is sent via cranial nerve 2. And cranial nerve 2 is the optic nerve. So as you can see here in the picture that there is a signal being sent through the cranial nerve 2 and that signal is going to get to the pretectal nuclei, which is located in the midbrain, and that will activate bilaterally the Edinger-Westphal nuclei. So both of the Edinger-Westphal nuclei are going to get activated even if you just shine the light in one eye. And since we have already talked about the Edinger-Westphal nucleus, we know that when Edinger-Westphal nuclei are activated, they will cause pupillary constrictions bilaterally. So this is the consensual reflex, which means that even if you shine the light in only one eye, it will result in bilateral pupillary constriction. What is Marcus gun pupil and why does it happen? Marcus gun pupil is afferent pupillary defect and it happens due to optic nerve damage or retinal detachment. Describe the clinical presentation of Marcus gun pupil. The clinical presentation of this would be decreased bilateral pupillary constriction when the light is shown in the affected eye relative to the unaffected eye. What test is used to diagnose Marcus gun pupil? The test used to diagnose Marcus gun pupil is the swinging flashlight test. Cranial nerve 3, oculomotor nerve. What are the components of cranial nerve 3? Cranial nerve 3 has both motor and parasympathetic components. Motor is for central and parasympathetic is for peripheral. What are the motor functions of cranial nerve 3? The motor functions of cranial nerve 3 is to provide motor output to the ocular muscles. What are the conditions that can affect the motor output to the ocular muscles? Motor output to ocular muscles is affected primarily by vascular disease such as diabetes, in which glucose is turned into sorbitol. And the reason vascular disease will lead to dysfunction in the ocular muscle is because there's going to be decreased diffusion of oxygen and nutrients to the interior fibers. So basically, if there's vascular disease, that would mean that there is decrease in oxygen and nutrients going to the ocular muscles, and this would lead to problems with the ocular muscles. What is a sign indicative of ocular muscle dysfunction? A sign of ocular muscle dysfunction is ptosis and a down and out gaze. Describe what happens if there is a compression of cranial nerve 3. If there is compression of cranial nerve 3, it will have an effect on the parasympathetic output because fibers on the periphery are the first to be affected by compression. What are the causes that can lead to compression of cranial nerve 3? The causes of compression on cranial nerve 3 can be posterior communicating artery aneurysm and uncal herniation. What is uncus? Uncus is an anterior extremity of the parahippocampal gyrus. What are some of the signs of cranial nerve 3 compression? Some of the signs of cranial nerve 3 compression includes diminished or absent pupillary light reflex as well as blown pupil. Retinal detachment. Describe the process of retinal detachment that leads to vision loss. In retinal detachment, if there is separation of the neurosensory layer of the retina from the outermost pigmented epithelium, this will lead to degeneration of the photoreceptors, and that will eventually lead to vision loss. What is neurosensory layer of the retina? The neurosensory layer of the retina is the photoreceptor layer with rods and cones. What is the function of the outermost pigmented epithelium? The function of the outermost pigmented epithelium is to shield excess light and support the retina. What are the causes of retinal detachment? The causes of retinal detachment may be secondary to retinal breaks, diabetic traction, and inflammatory effusion. What is the cause of retinal breaks? The cause of retinal breaks is due to posterior vitreal detachment, and this leads to vitreoretinal traction, and that can lead to breaks, and this condition happens more commonly in people with high myopia. What do you see in condition of posterior vitreous detachment? You see flashes and floaters. What can be the eventual consequence of retinal breaks? An eventual consequence of retinal breaks can be monocular loss of vision, like a curtain drawn down, and this is considered a surgical emergency. Age-related macular degeneration. What is macula? Macula is an oval-shaped, highly pigmented yellow spot near the center of the retina of the human eye. What does degeneration of the macula causes? Degeneration of the macula causes distortion, which is known as metamorphopsia, and then eventual loss of central vision, which is known as scotomas. Define scotomas. Scotomas is a partial loss of vision or blind spot in otherwise normal visual field. Which age-related macular degeneration is the most common? Dry age-related macular degeneration is the most common because it occurs in over 80% of the patient versus wet age-related macular degeneration, which occurs in 10 to 15% of the patients. Describe the dry or the non-exudative age-related macular degeneration. The dry, non-exudative age-related macular degeneration is when there is deposition of yellowish extracellular material beneath the retinal pigmented epithelium. This material is called drusen, and this leads to gradual decrease in vision. How can the progression of dry, non-exudative age-related macular degeneration be prevented? The progression of this condition can be prevented with multivitamins and antioxidant supplements. What is wet exudative age-related macular degeneration? Wet exudative age-related macular degeneration is when there is rapid loss of vision due to bleeding secondary to choroidal neovascularization. What is the treatment option for wet exudative age-related macular degeneration? The treatment option for this is antivascular endothelial growth factor injections, also known as anti-VEGF, or with lasers. Visual field defects. Please refer to the picture of visual field defect before answering any of the questions.
And remember, in the visual field defect, the gray area that's shaded, that is actually the blinded area. The clear white space is the actual visual field. What would be the result in right optic nerve damage? The result of right optic nerve damage would be right anopia. And anopia just means complete blindness. What would be the end result of optic chiasm damage? Optic chiasm damage would lead to bitemporal hemianopia. What would be the end result in right optic tract damage? Right optic tract damage would lead to left homonymous hemianopia. So basically in this you would not be able to see on the left side of both the eyes. One other thing to remember here is that in right lateral geniculate body damage, you would have the same exact result where you have the left homonymous hemianopia. What would be the end result if the right Myers loop of the temporal lobe was damaged? In right Myers loop damage, it would lead to left upper quadrantic anopia. What are the conditions that can lead to the right Myers loop damage? Right Myers loop damage can occur due to right temporal lesion or middle cerebral artery stroke. What would be the end result of dorsal optic radiation of the parietal lobe damage? Dorsal optic radiation of the parietal lobe would lead to left lower quadrantic anopia. What are the causes that can lead to dorsal optic radiation of the parietal lobe damage? Dorsal optic radiation can be damaged with right parietal lesion or with middle cerebral artery stroke. What would be the end result if the primary visual cortex is damaged? If the primary visual cortex is damaged, as you can see here with number 6, it would lead to homonymous hemianopia, and this can be with or without macular sparing, depending on the site of the lesion. What would be the end result if the left macula is damaged? When the left macula is damaged, it would lead to central scotoma, and central scotoma just means a central blind spot. Where do nerve fibers of the Meyer's loop come from? The nerve fibers of the Meyer's loop come from inferior retina. Describe the route of Meyer's loop. The fibers of Meyer's loop loops around inferior horn of the lateral ventricle. Where do nerve fibers of dorsal optic radiation come from? The nerve fibers of dorsal optic radiation comes from the superior retina. Describe the path of the dorsal optic radiation fibers. Dorsal optic radiation fiber takes the shortest path via the internal capsule. Describe how the image that we see is perceived by the primary visual cortex. When an image first hits the primary visual cortex, it's upside down and left-right reversed. Please refer to the picture under internuclear ophthalmoplegia to answer the following questions. What is another name for internuclear ophthalmoplegia? Another name for internuclear ophthalmoplegia is MLF syndrome, and MLF stands for medial longitudinal fasciculus. What is medial longitudinal fasciculus? Medial longitudinal fasciculus are pair of tracts that allow the crosstalk between cranial nerve 6 and cranial nerve 3 nuclei. And because of this connection, it coordinates both eyes to move in the same horizontal direction. Why is the medial horizontal fasciculus highly myelinated? The reason medial longitudinal fasciculus is highly myelinated is because it must communicate quickly so eyes could move at the same time, and because of this it requires high amounts of myelination. What is a condition that can lead to lesion of the medial longitudinal fasciculus? Medial longitudinal fasciculus can happen in conditions that leads to demyelination, such as multiple sclerosis. What does lesion of the medial longitudinal fasciculus cause? The lesion of medial longitudinal fasciculus causes the internuclear ophthalmoplegia. Describe what happens in order to cause the internuclear ophthalmoplegia. Internuclear ophthalmoplegia happens because there is lack of communication between cranial nerve 6 nucleus and cranial nerve 3 nucleus. And the lack of communication is such that when cranial nerve 6 nucleus goes on and activates the ipsilateral lateral rectus muscle, on the contralateral side, cranial nerve 3 nucleus does not stimulate the medial rectus. So basically, when cranial nerve 6 is firing on one side, on the other side, if cranial nerve 3 does not respond and fire, this will cause the lack of communication, which would lead to internuclear ophthalmoplegia. What is the end result of internuclear ophthalmoplegia? The end result of internuclear ophthalmoplegia would be that the abducting eye will get nystagmus, and this is because cranial nerve 6 will overfire to stimulate cranial nerve 3. Is convergence affected in internuclear ophthalmoplegia? The answer is no. Convergence is normal in internuclear ophthalmoplegia. Define convergence. Convergence is simultaneous inward movement of both eyes towards each other, and this is usually done to focus on a particular object. What is the mnemonic to help you remember that the MLF syndrome occurs in multiple sclerosis? The mnemonic to help you remember this is just remember MLF has that M in it, and multiple sclerosis also has the M. Describe the normal coordinated process that occurs to allow you to look to the left. In order for your eyes to look to the left, a few coordinated processes must happen, and that includes when the left nucleus of cranial nerve 6 fires, it will cause the contraction to occur in the left lateral rectus muscle. And at the same time, it will also stimulate the contralateral right nucleus of cranial nerve 3. And it's doing this via the right medial longitudinal fasciculus.
and when cranial nerve 3 has fired, it will cause the contraction to happen in the right medial rectus muscle. And when right medial rectus muscle is contracted and the left lateral rectus muscle is contracted, it will cause both the eyes to look in one direction, and this is the complete coordinated movement when you want to look to the left. What is dementia? Dementia is a loss of brain function that occurs with certain disease. It affects the memory, thinking, language, judgment, and behavior. Name some conditions that can lead to dementia. Conditions that can lead to dementia include Alzheimer's disease, Pick's disease in which there would be frontotemporal dementia, Lewy body dementia, and Creutzfeldt-Jakob disease. What is the most common cause of dementia in elderly? The most common cause of dementia in elderly is Alzheimer's disease. Which group of patients have high risk of developing Alzheimer's disease? Down syndrome patients have a high risk of developing Alzheimer's. What percent of Alzheimer's disease account for the familial form of Alzheimer's? Familial form accounts for 10% of all Alzheimer's disease. Name the 3 altered protein and their respective chromosome that leads to early onset Alzheimer's disease. The 3 altered protein includes amyloid precursor protein or APP, which is located on chromosome 21. Second is presenilin 1 protein, which is located on chromosome 14. And the third is presenilin 2, which is located on chromosome 1. Name the altered protein and its respective chromosome that leads to late onset Alzheimer's disease. The altered protein that leads to late onset Alzheimer's disease is apolipoprotein E4, which is located on chromosome 19. Which apolipoprotein is protective against Alzheimer's disease? Apolipoprotein E2 is protective against Alzheimer's disease, and it's located on chromosome 19 as well. What is a gross finding seen in Alzheimer's disease? The gross finding seen in Alzheimer's disease is widespread cortical atrophy. Synthesis of which neurotransmitter has decreased in Alzheimer's disease? In Alzheimer's disease, there is decrease in acetylcholine. What are the histologic findings seen in Alzheimer's disease? The histologic findings of Alzheimer's disease include senile plaques and neurofibrillary tangles. What are senile plaques? Senile plaques are extracellular deposits of beta amyloid in the gray matter of the brain. What can be the eventual consequence if there is too much extracellular deposits of beta amyloid in the brain? If there is too much beta amyloid core, it would lead to amyloid angiopathy, and this can eventually lead to intracranial hemorrhage. How are senile plaques formed? Senile plaques are formed when beta amyloid is cleaved from the amyloid precursor protein. What are neurofibrillary tangles? Neurofibrillary tangles are intracellular, abnormally phosphorylated tau protein that becomes insoluble cytoskeletal elements. What are neurofibrillary tangles indicative of? Neurofibrillary tangles correlate with degree of dementia. So the more you see, the greater advancement in the disease. What is Pick's disease? Pick's disease is a rare neurodegenerative disease that causes progressive destruction of nerve cells in the brain. What are the classic clinical presentations seen with Pick's disease? The classic clinical presentation of Pick's disease includes dementia, aphasia, Parkinsonian aspects, and changes in personality. What is aphasia? Aphasia is the loss of ability to understand or express speech. What areas of the brain are affected in Pick's disease? The area of the brain that's affected in Pick's disease is the frontal and the temporal lobe. What areas of the brain are spared by Pick's disease? The areas of the brain spared by Pick's disease includes the parietal lobe and the posterior 2/3 of the superior temporal gyrus. What are Pick bodies? Pick bodies are spherical tau protein aggregates. What type of atrophy is seen in Pick's disease? Pick's disease leads to frontotemporal atrophy. What is Lewy body dementia? Lewy body dementia is Parkinsonianism with dementia and hallucinations. What are the clinical findings of Lewy body dementia? The clinical findings in Lewy body dementia is alpha-synuclein defect. What are Lewy bodies? Lewy bodies are clumps of alpha-synuclein and ubiquitin proteins in neurons. What is Creutzfeldt-Jakob disease? Creutzfeldt-Jakob disease is a rapidly progressive dementia with myoclonus. What is the progressive rate of Creutzfeldt-Jakob disease? Creutzfeldt-Jakob disease is a rapidly progressive dementia that happens within weeks to months. What is myoclonus? Myoclonus is spasmodic, jerky contraction of group of muscles. Describe the gross finding in Creutzfeldt-Jakob disease. In Creutzfeldt-Jakob disease, the brain tissue develops holes and takes a sponge-like texture, and that's why it's referred to as spongiform cortex. What is the cause of Creutzfeldt-Jakob disease? The cause of Creutzfeldt-Jakob disease are infectious proteins called prions. What are prions? Prions are misfolded proteins which replicate by converting their properly folded counterparts. What are the other causes of dementia? The other causes of dementia is multi-infarct dementia, and this is the second most common cause of dementia in elderly. Along with multi-infarct, syphilis, HIV, vitamin B1, B3, or B12 deficiency can also lead to dementia, along with Wilson's disease and NPH, which stands for normal pressure hydrocephalus. What is multiple sclerosis? Multiple sclerosis is autoimmune inflammation and demyelination of CNS that occurs in the brain and the spinal cord. What are the clinical presentations seen with multiple sclerosis? Patients with multiple sclerosis can present with optic neuritis, in which they have sudden loss of vision, MLF syndrome, in which they would have internuclear ophthalmoplegia, hemiparesis, hemisensory symptoms, or bladder and bowel incontinence. Define hemiparesis. Hemiparesis is the weakness on one side of the body. What is hemisensory symptoms? Hemisensory symptoms is the loss of sensation or feeling of unusual sensation in one side of the body. What type of clinical course does multiple sclerosis have? Multiple sclerosis has a relapsing and remitting course. What group of patients are most commonly affected with multiple sclerosis? Multiple sclerosis occurs most often in women in their 20s and 30s, and the disease is more common in whites. What is Charcot's classic triad of multiple sclerosis? Charcot's classic triad of multiple sclerosis is SIN, and SIN stands for S for scanning speech, I for intention tremor and incontinence along with internuclear ophthalmoplegia, and N for nystagmus. What are the clinical findings observed in multiple sclerosis? The clinical findings observed in multiple sclerosis includes increase in protein in the cerebrospinal fluid, namely immunoglobulin G. Oligoclonal bands are also seen, which are diagnostic, and you also observe periventricular plaques with destruction of the axons. What are periventricular plaques? Periventricular plaques are areas of oligodendrocyte loss and reactive gliosis. What is the gold standard diagnostic test for multiple sclerosis? For multiple sclerosis, MRI is gold standard. What are all the drugs used in the treatment of multiple sclerosis? The drugs used in the treatment of multiple sclerosis include beta interferon, immunosuppression, and natalizumab. What is the treatment option for neurogenic bladder in multiple sclerosis? The treatment for neurogenic bladder is catheterization or muscarinic antagonist. What are the drugs used in the treatment of spasticity in multiple sclerosis? Spasticity in multiple sclerosis is treated with baclofen or GABA receptor agonist. What drugs are used in the treatment of pain in multiple sclerosis? The drugs used in the treatment of pain in multiple sclerosis are opioids. What is acute inflammatory demyelinating polyradiculopathy? Acute inflammatory demyelinating polyradiculopathy is the most common variant of Guillain-Barré syndrome. It's an autoimmune condition that destroys the Schwann cells, and this leads to inflammation and demyelination of the peripheral nerves and motor fibers. What is the end result of acute inflammatory demyelinating polyradiculopathy? The end result is systemic ascending muscle weakness and paralysis beginning in the lower extremities and moving upwards. This condition also results in facial paralysis in 50% of the cases. What type of functions are severely affected in acute inflammatory demyelinating polyradiculopathy? In acute inflammatory demyelinating polyradiculopathy, autonomic functions may be severely affected, and this results in cardiac irregularities, hypertension, or hypotension. What is the prognosis of acute inflammatory demyelinating polyradiculopathy? In acute inflammatory demyelinating polyradiculopathy, almost all patients survive, and the majority recovers completely after a few weeks to months. What are the clinical findings seen in acute inflammatory demyelinating polyradiculopathy? The findings of acute inflammatory demyelinating polyradiculopathy is increase in cerebrospinal fluid protein with normal cell count. So this is the albuminocytologic dislocation. What does high levels of protein lead to? High levels of protein leads to papilledema. What is papilledema? Papilledema is the optic disc swelling that is caused by increase in intracranial pressure. Name some infections that can lead to acute inflammatory demyelinating polyradiculopathy. The infections that can lead to this includes Campylobacter jejuni and cytomegalovirus. How does infections with Campylobacter jejuni and cytomegalovirus lead to acute inflammatory demyelinating polyradiculopathy? The reason this happens is due to autoimmune attack of the peripheral myelin due to molecular mimicry, inoculation, and stress, but it does not have a definitive link to these pathogens. Describe the treatment process of acute inflammatory demyelinating polyradiculopathy. The treatment process includes respiratory support until full recovery, along with treatment with plasmapheresis and IV immunoglobulins. What is plasmapheresis? Plasmapheresis is a method of removing blood plasma from the body by withdrawing blood and separating it into plasma and cells and transfusing the cells. Name a few non-common demyelinating and dysmyelinating diseases. Other demyelinating and dysmyelinating diseases includes progressive multifocal leukoencephalopathy, also known as PML, acute disseminated post-infectious encephalomyelitis, metachromatic leukodystrophy, Charcot-Marie Tooth disease, and Krebs disease. What is progressive multifocal leukoencephalopathy? PML is when there is demyelination of the CNS due to destruction of oligodendrocytes. What is PML associated with? PML is associated with JC virus or the John Cunningham virus, which is a type of human polyomavirus. What group of patient is PML most commonly seen with? PML most commonly is seen in 2 to 4% of AIDS patients in which they have reactivation of the latent viral infection. Describe the disease course of progressive multifocal leukoencephalopathy. PML is rapidly progressive and is usually fatal. What is acute disseminated post-infectious encephalomyelitis? Acute disseminated post-infectious encephalomyelitis is a multifocal perivenular inflammation and demyelination after infection, commonly with measles or varicella-zoster virus, and it can also happen after certain vaccinations such as rabies or smallpox vaccination. Define perivenular. Perivenular just means around a vein, so in this condition there would be multifocal inflammation around a vein. What is metachromatic leukodystrophy? Metachromatic leukodystrophy is an autosomal recessive lysosomal storage disease, and it most commonly occurs due to aryl sulfatase A deficiency. Describe how aryl sulfatase A deficiency can lead to metachromatic leukodystrophy. The way this happens is with aryl sulfatase A deficiency, this would lead to buildup of sulfatides, and this leads to impaired production of the myelin sheath. What is another name for Charcot-Marie Tooth disease? Charcot-Marie Tooth disease is also known as hereditary motor and sensory neuropathy, HMSN. What is Charcot-Marie Tooth disease? Charcot-Marie Tooth disease is a group of progressive hereditary nerve disorders related to the defective production of proteins involved in the structure and function of peripheral nerves or the myelin sheath. So basically these are inherited disorders of the peripheral nervous system characterized by progressive loss of muscle tissue and touch sensation across various parts of the body. What is Krebs disease? Krebs disease is an autosomal recessive lysosomal storage disease due to the deficiency of the enzyme galactocerebrosidase. Describe the process in which the myelin sheath gets damaged in Krebs disease. The way the myelin sheath gets damaged in Krebs disease is due to the buildup of galactocerebroside, and galactocerebroside buildup will destroy myelin sheath, and this is all happening due to the deficiency of galactocerebrosidase. What are seizures? Seizures are an episode of abnormal electrical activity in the brain. They are characterized by synchronized high-frequency neuronal firing. What are the two broad categories of seizures? The two broad categories of seizures are partial or focal seizures and generalized seizures. What are partial or focal seizures? Partial or focal seizures are seizures that affect one area of the brain. Where do partial or focal seizures originate from? Partial or focal seizures most commonly originate in the medial temporal lobe. Describe the onset of partial focal seizure. Partial or focal seizures can often occur after a seizure aura, and seizure aura is just a condition to describe some symptoms that you get before a seizure, such as visual changes, hearing voices or sounds, feeling numbness, anxiety, and nausea. So after you feel these things, you end up getting a seizure, which would be a partial or focal seizure, but it can become a generalized seizure. Name the two partial or focal seizures. The two partial or focal seizures are simple partial seizure and a complex partial seizure. What is simple partial seizure? Simple partial seizure is when you have a seizure with consciousness intact, and this includes motor, sensory, autonomic, and psychic consciousness. What is complex partial seizure? Complex partial seizure is when a seizure happens with impaired consciousness. What is epilepsy? Epilepsy is a disorder of recurrent seizures. One thing to note about this is febrile seizures are not epilepsy. What are febrile seizures? Febrile seizures are seizures that occur during fever. What is status epilepticus? Status epilepticus is continuous seizures for more than 30 minutes or recurrent seizures without regaining consciousness between seizures for more than 30 minutes, and this condition is considered a medical emergency. What are the causes of seizures in children? The causes of seizures in children include genetic factor, infections which would lead to febrile seizures, trauma, congenital, and metabolic reasons. What are the causes of seizures in adult? The causes of seizures in adult includes tumors, trauma, stroke, and infection. What are the cause of seizures in elderly? The cause of seizures in elderly includes stroke, tumor, trauma, metabolic, and infections. One thing to note here is when we talked about the common causes of seizures, we said it in order from the most common to the least common for that age group. What are generalized seizures? Generalized seizures are a type of seizures that impairs consciousness and distorts the electrical activity of the whole or large portion of the brain. Name the 5 types of generalized seizures. The 5 types of generalized seizures include absence or petit mal seizures, myoclonic seizures, tonic-clonic or grand mal seizures, tonic seizures, and atonic seizures. What are absence or petit mal seizures? Absence or petit mal seizures are seizures that last less than 20 seconds, and the person that's experiencing the seizure is often unaware of the episode. In absence or petit mal seizure, the person does not have any sort of confusion after the seizure, and they are often with just a blank stare during seizure. Describe what you see on an EEG during absence seizure. In absence or petit mal seizures on an EEG, you would see fast, about 3 Hz, generalized spike wave discharges. What are myoclonic seizures? Myoclonic seizures can be described as jumps because they cause rapid contraction and relaxation of the muscle. So in myoclonic seizures, there are quick and repetitive jerks. What are tonic-clonic or grand mal seizures? Tonic-clonic or grand mal seizures are seizures in which there is alternating stiffening and movement. What are tonic seizures? Tonic seizures are seizures that occur with stiffening, so the body constricts and hardens up during a seizure. What are atonic seizures? Atonic seizures are when the person drops to the floor during a seizure, and this is commonly mistaken for fainting. Differentiating headaches. What is headache? Headache is pain due to irritation of structures such as the dura, cranial nerves, or the extracranial structures. Name the 3 different types of headaches. The 3 different types of headaches include cluster headaches, tension headaches, and migraines. What is the localization of cluster headaches? Cluster headaches are unilateral. What is the duration of cluster headache? The duration of cluster headaches is 15 minutes to 3 hours, and it's repetitive. Describe cluster headaches. Cluster headaches are repetitive, brief headaches. They cause excruciating periorbital pain with lacrimation and rhinorrhea. Define rhinorrhea. Rhinorrhea is the persistent watery mucus discharge from the nose. What condition can be induced by cluster headaches? Cluster headaches may induce Horner syndrome, and Horner syndrome is when there is drooping of the eyelids, called ptosis, when there is constriction of the pupils, called miosis, and when there is anhidrosis, which is decreased sweating. Are males or females more likely to get cluster headaches? Males are more likely to get cluster headaches. What is the treatment of cluster headaches? Cluster headaches can be treated with inhaled oxygen and sumatriptan. What is the localization of tension headaches? Tension headaches occur bilaterally. What is the duration of tension headaches? The duration of tension headaches is more than 30 minutes, typically 4 to 6 hours, and the headache is constant. Describe tension headaches. In tension headache, there is steady pain, there is no photophobia or phonophobia, and there is no aura. Does tension headaches require any treatment? No, tension headaches do not require any treatment, just sleep and resting will stop the headaches. What is the localization of migraines? Migraines are unilateral. What is the duration of migraines? Migraines can last from 4 to 72 hours. Describe migraine headaches. In migraine headaches, there is pulsating pain, which is throbbing pain, with nausea, photophobia, or phonophobia. And in migraine headaches, there may be aura. What are the causes of migraine headaches? The causes of migraine headaches are due to irritation of cranial nerve 5, meninges, or blood vessels. What is the reason for pain of migraine headache? The reason pain occurs in migraine headaches is because of the blood vessels will release substance P, CGRP, and vasoactive peptides. What are the treatments of migraine headaches? Migraine headaches can be treated with abortive therapies like triptans, and for prophylactic they should be given propranolol or topiramate. What is abortive therapies? Abortive therapies is the treatment that is intended to stop the medical condition from progressing any further. Name some other less common causes of headaches. The other causes of headaches include subarachnoid hemorrhage, in which the patient complains of the worst headache of my life. Meningitis can cause headaches. Hydrocephalus, neoplasia, and arthritis all have potential of causing headaches. What is hydrocephalus? Hydrocephalus is a condition in which the fluid accumulates in the brain. How do you differentiate cluster headaches from trigeminal neuralgia? Cluster headaches can be differentiated from trigeminal neuralgia based on the duration of the headaches. Describe the trigeminal neuralgia-related headaches. Trigeminal neuralgia produces repetitive shooting pain in distribution of the cranial nerve 5 that lasts typically less than 1 minute. Describe the duration of pain associated with cluster headaches. The pain in cluster headaches lasts much longer than it does in trigeminal neuralgia, because in trigeminal neuralgia it only lasts less than a minute, but in cluster headaches it lasts more than 15 minutes. What is vertigo? Vertigo is a sensation in which a person feels like they're spinning while they're actually stationary. Vertigo is a subtype of dizziness, but is distinct from lightheadedness. What is peripheral vertigo? Peripheral vertigo is a type of dizziness that's more common, and it is caused due to inner ear problems such as semicircular canal debris, vestibular nerve infection, and Meniere's disease. What would happen in positional testing in peripheral vertigo? In positional testing of peripheral vertigo, there would be delayed horizontal nystagmus, and this is what the clinician needs to observe in Epley maneuver. What is central vertigo? Central vertigo is dizziness that occurs due to brainstem or cerebellar lesions. What conditions causes central vertigo? Central vertigo is caused by strokes affecting the vestibular nuclei or the posterior fossa tumor. What are the clinical findings seen in central vertigo? The clinical findings of central vertigo is directional change of nystagmus, skew deviation, diplopia, and dysmetria. Define diplopia. Diplopia is double vision. Define dysmetria. Dysmetria is a lack of coordination of movement in which there is undershoot or overshoot of intended position with either the hand, arm, leg, or even the eyes. What is observed in positional testing in central vertigo? Positional testing in central vertigo will show immediate nystagmus in any direction, and the nystagmus can change in direction. Neurocutaneous disorders. Name the 4 neurocutaneous disorders. The 4 neurocutaneous disorders include Sturge-Weber syndrome, tuberous sclerosis, neurofibromatosis type 1, also known as von Recklinghausen disease, and von Hippel-Lindau disease.
What is Sturge-Weber syndrome? Sturge-Weber syndrome is a congenital disorder with port wine stains, and port wine stains are also known as nevus flemmus, and this typically occurs at the ophthalmic nerve distribution. Along with port wine stains in Sturge-Weber syndrome, you also see ipsilateral leptomeningeal angiomas and pheochromocytomas. Define the word leptomeningeal. Leptomeningeal just means relating to the thin meninges, so it's a term used to refer to pia matter and the arachnoid matter. What are some of the conditions that can be caused by Sturge-Weber syndrome? Sturge-Weber syndrome can cause glaucoma, seizures, hemiparesis, and mental retardation, and these all occur sporadically. Define hemiparesis. Hemiparesis just means weakness on one side of the body. What is tuberous sclerosis? Tuberous sclerosis is a rare multisystem genetic disease that causes non-malignant tumors to grow in the brain and other vital organs such as kidneys, heart, eyes, lungs, and the skin. What is the mnemonic to help you remember everything that happens in tuberous sclerosis? The mnemonic to help you remember this is just remember hamartomas, and that's spelled Hamartomas. H standing for hamartomas in the CNS and the skin, A standing for adenoma sebaceum, which are cutaneous angiofibromas, M stands for mitral regurgitation, A stands for ash leaf spots, R stands for cardiac rhabdomyomas, T is for tuberous sclerosis, O standing for autosomal dominant, and dominant has the letter O in it, M for mental retardation, A for renal angiomyolipomas, and S for seizures. What is another name for neurofibromatosis type 1? Another name for neurofibromatosis type 1 is von Recklinghausen disease. What are the classic clinical presentations seen with neurofibromatosis type 1? The classic clinical presentation of neurofibromatosis type 1 is cafe au lait spots, Lisch nodules, and Lisch nodules are pigmented iris hamartomas, neurofibromas in the skin, optic gliomas, and pheochromocytomas. Describe the pattern of inheritance in neurofibromatosis type 1. Neurofibromatosis type 1 is an autosomal dominant condition in which there is 100% penetrant and it has variable expression. Name the mutated gene and its location in neurofibromatosis type 1. In neurofibromatosis type 1, the mutated gene is the NF1 gene and it's located on chromosome 17. What is von Hippel-Lindau disease? Von Hippel-Lindau disease is a rare autosomal dominant genetic condition that predisposes individuals to benign and malignant tumors. The type of benign and malignant tumors that can arise in this includes cavernous hemangiomas in the skin, mucosa, and other organs, along with bilateral renal cell carcinoma, as well as hemangioblastoma in the retina, brainstem, and cerebellum. Along with all these tumors, there can also be pheochromocytomas. What mutation can lead to von Hippel-Lindau disease? Von Hippel-Lindau disease occurs due to mutated tumor suppressor VHL gene on chromosome 3. Name all the adult primary brain tumors. The adult primary brain tumors includes glioblastoma multiforme, which is grade 4 astrocytoma, meningioma, schwannoma, oligodendroglioma, and pituitary adenoma. What is glioblastoma multiforme? Glioblastoma multiforme, also known as grade 4 astrocytoma, is the most common primary brain tumor. It's malignant with less than 1 year life expectancy, and it's found in cerebral hemispheres. What is butterfly glioma? Butterfly glioma is when glioblastoma multiforme crosses the corpus callosum, giving it an appearance of a butterfly, and that is why the term butterfly glioma. What immunohistochemical is used to stain astrocytes? Glial fibrillary acidic protein is used to stain astrocytes. Describe the pathogenesis of glioblastoma multiforme. The pathogenesis of glioblastoma multiforme is characterized by the presence of small area of necrotizing tissue that is surrounded by anaplastic cells. In glioblastoma multiforme, there are pseudopulsating pleomorphic tumor cells with areas of necrosis and hemorrhage. What is meningioma? Meningioma is the second most common primary brain tumor. Where do meningiomas occur?
Meningiomas most often occur in convexities of hemispheres near the surface of the brain and at the parasagittal region. Describe the location of meningiomas. Meningiomas arise from the arachnoid cells and are extraaxial, which means they are external to the brain parenchyma and may have dural attachment, which is considered the tail. Describe the degree of aggression in meningiomas. Meningiomas are not aggressive tumors, they are typically benign and resectable. These tumors are often asymptomatic but may present with seizures or focal signs. Describe the histologic features of meningiomas. In meningioma, cells are relatively uniform with tendency to encircle one another, forming whorls and psammoma bodies. What are psammoma bodies? Psammoma bodies are laminated calcific concretions. What are schwannomas? Schwannomas are the third most common primary brain tumor, and they arise from Schwann cells. What cranial nerve is affected commonly by schwannomas? Schwannomas most often affect cranial nerve 8, which is the vestibulocochlear nerve. What is the name of schwannomas that are localized to cranial nerve 8? Schwannomas that are localized to cranial nerve 8 are called acoustic schwannomas, also known as acoustic neuromas. What are the treatment options for schwannomas? The treatment option for schwannoma is to resect the tumor or to treat it with stereotactic radiosurgery. What particular site are schwannomas found at? Schwannomas are usually found at the cerebellopontine angle. What tumor marker is indicative of schwannoma? The tumor marker for schwannoma is S100 protein. What condition leads to the formation of bilateral acoustic schwannoma? Bilateral acoustic schwannomas is found in neurofibromatosis type 2. What is oligodendroglioma? Oligodendroglioma is a relatively rare, slow-growing tumor that most often occurs in the frontal lobe. What is the term used to describe the capillary patterns in oligodendroglioma? The term used to describe the capillary pattern is called the chicken wire capillary pattern. What is the classic term used to describe oligodendrocytes and why? The term used to describe oligodendrocytes is the fried egg cells, and the reason for this is because they have round nuclei with clear cytoplasm. What happens to oligodendrocytes in oligodendroglioma? In oligodendrogliomas, the oligodendrocytes are usually calcified. What is the most common pituitary adenoma? The most common pituitary adenoma is prolactinoma. What problems can pituitary adenoma cause? Pituitary adenoma can lead to bitemporal hemianopia, and this is due to the pressure it exerts on the optic chiasm, and it can lead to hyper or hypopituitarism. Define hemianopia. Hemianopia is the blindness in one half of the visual field. Name all the childhood primary brain tumors. The childhood primary brain tumors include pilocytic, low-grade astrocytoma, medulloblastoma, ependymoma, hemangioblastoma, and craniopharyngioma. What is pilocytic astrocytoma? Pilocytic astrocytoma is a neoplasm of the brain that occurs more often in children and in young adults. It's a neoplasm that is usually well circumscribed, which means that it grows within its limits and is often found in the posterior fossa, such as in the cerebellum, but may also be supratentorial. What protein is pilocytic astrocytoma positive for? Pilocytic astrocytoma is GFAP positive, and GFAP stands for glial fibrillary acidic protein. Describe the prognosis of pilocytic astrocytoma. The prognosis is generally good and the tumors are usually benign. What is the characteristic histological feature seen in pilocytic astrocytoma? In pilocytic astrocytoma, there is usually presence of Rosenthal fibers. What are Rosenthal fibers? Rosenthal fibers are thick, elongated, worm-like or corkscrew eosinophilic bundles that are found on H&E staining, and their gross appearance is cystic and solid. What is medulloblastoma? Medulloblastoma is a highly malignant cerebellar tumor, and it's a form of primitive neuroectodermal tumor. What can be a consequence if there is overgrowth of medulloblastoma? Medulloblastoma can compress the fourth ventricle, and that will lead to hydrocephalus. What is hydrocephalus? Hydrocephalus is a condition in which fluid accumulates in the brain. Describe the type of metastasis that is seen with medulloblastoma. Medulloblastoma can send drop metastasis to the spinal cord. What is drop metastasis? Drop metastasis is when there is an intradural extramedullary spinal metastasis that arises from the intracranial lesions. So when this happens, it's called drop metastasis. What is a highly characteristic formation seen in medulloblastoma? In medulloblastoma, there is formation of Homer right rosettes. Describe the gross and histologic characteristic features of Homer right rosettes. Homer right rosettes appear solid in gross appearance and are small blue cells in histologic appearance, and they are also radiosensitive. What is ependymoma? Ependymoma are ependymal cell tumors most commonly found in the fourth ventricle. What can be the consequence if ependymoma grows too large? If the ependymoma becomes too large, it can cause hydrocephalus. What is hydrocephalus? Hydrocephalus is buildup of fluid inside the skull that leads to brain swelling. Describe the prognosis of ependymoma. The prognosis of ependymoma is generally poor. What are the characteristic features seen in ependymoma? Ependymoma, you see characteristic perivascular pseudorosettes, as well as rod-shaped blepharoplasts, which are the basal ciliary bodies found near the nucleus. What are hemangioblastoma? Hemangioblastoma are tumors of the central nervous system that originate from the vascular system. Where are hemangioblastomas most often found? Hemangioblastomas are most often found in the cerebellum. What condition can hemangioblastomas be associated with? Hemangioblastomas are associated with von Hippel-Lindau syndrome when they are found with retinal angiomas. What protein hormone can hemangioblastomas produce, and what would that result in? Hemangioblastomas can produce erythropoietin, and this can lead to secondary polycythemia. What are the characteristic features observed in hemangioblastoma? In hemangioblastoma, you see foamy cells and high vascularity are characteristic. What is craniopharyngioma? Craniopharyngioma is a benign tumor that develops near the pituitary gland. Describe the reason why craniopharyngioma and pituitary adenoma are sometimes confused. The reason why this confusion occurs is because they can both cause bitemporal hemianopia and their location are generally similar. What tumor is the most common childhood supratentorial tumor? Craniopharyngioma is the most common childhood supratentorial tumor. What are craniopharyngiomas derived from? Craniopharyngiomas are derived from remnants of Rathke's pouch. What kind of calcification is seen in craniopharyngioma? The type of calcification seen with craniopharyngioma is the tooth enamel-like calcification. Name the 4 different types of herniation syndromes. The different type of herniation includes cingulate or subfalcine herniation, which occurs under the falx cerebri. The second type of herniation is the downward transtentorial or central herniation. The third is uncal herniation, and the fourth is the cerebellar tonsillar herniation into foramen magnum. What can be the consequence of cingulate or subfalcine herniation? Cingulate or subfalcine herniation can lead to compression of the anterior cerebral artery. Where is the uncus located? Uncus is located in the medial temporal lobe. What can be a consequence of cerebellar tonsillar herniation? The consequence of cerebellar tonsillar herniation is coma and death, and this occurs if these herniation compresses the brainstem. What is the purpose of glaucoma drugs? The purpose of glaucoma drugs is to decrease intraocular pressure, and this is done by decreasing the amount of aqueous humor, and that can be achieved by either inhibiting synthesis of aqueous humor, and it can also be achieved by inhibiting secretion of aqueous humor or increasing the drainage of aqueous humor. Name the 5 group of drugs that are used in the treatment of glaucoma. The group of drugs used in the treatment of glaucoma includes alpha agonists, beta blockers, diuretics, cholinomimetics, and prostaglandins. Name the alpha agonist drugs used in the treatment of glaucoma. The alpha agonist drugs that are used in the treatment of glaucoma includes epinephrine and brimonidine, which is an alpha-2 agonist. What is the mechanism of action of epinephrine? The mechanism of action of epinephrine is to decrease aqueous humor synthesis via vasoconstriction. What is the mechanism of action of brimonidine? The mechanism of action of brimonidine is to decrease aqueous humor synthesis. What are the side effects seen with epinephrine use? The side effect of epinephrine is mydriasis, and that's why it should not be used in the treatment of closed-angle glaucoma. What are the side effects seen with brimonidine use? The side effects of brimonidine use is blurry vision, ocular hyperemia, foreign body sensation, ocular allergic reaction, and ocular pruritus. Define hyperemia. Hyperemia is excessive amount of blood being supplied to an organ. What is pruritus? Pruritus is severe itching of the skin. Name the beta blockers used in the treatment of glaucoma. The beta blockers used in the treatment of glaucoma include timolol, betoxolol, and carteolol. What is the mechanism of action of beta blockers used in the treatment of glaucoma? The mechanism of action is to decrease aqueous humor synthesis. What are the side effects of beta blockers used in the treatment of glaucoma? Using beta blockers as a treatment in glaucoma does not have any pupillary or vision changes, but they may cause beta blocker related side effects on other systems. Name the diuretic that can be used in the treatment of glaucoma. The diuretic that can be used in the treatment of glaucoma is acetazolamide. What is the mechanism of action of acetazolamide used in the treatment of glaucoma? Acetazolamide can decrease aqueous humor synthesis via inhibition of carbonic anhydrase. What side effects may be caused with the use of acetazolamide for glaucoma? Acetazolamide does not cause any pupillary or vision changes, but it may lead to other systemic side effects, which we will talk about further in the renal chapter. Name the direct cholinomimetics that can be used in the treatment of glaucoma. The direct cholinomimetics that can be used in the treatment of glaucoma is pilocarpine and carbachol. Name the indirect cholinomimetics that can be used in the treatment of glaucoma. The indirect cholinomimetics include physostigmine and ecothiopate. What is the mechanism of action of direct cholinomimetics used in the treatment of glaucoma? The mechanism of action is to increase outflow of the aqueous humor, and this is done by causing contraction of the ciliary muscle, and that leads to opening of the trabecular meshwork. What drug is used in the treatment of glaucoma emergencies and why? The drug used in the treatment of glaucoma emergencies is pilocarpine, and the reason for this is because it's very effective at opening meshwork into canal of Schlemm. What are the side effects caused by cholinomimetics used in the treatment of glaucoma? The side effects of cholinomimetics is miosis and cyclospasms. Define cyclospasms. Cyclospasms are constriction of ciliary muscles. Name the prostaglandin used in the treatment of glaucoma. The prostaglandin that is used in the treatment of glaucoma is latanoprost, also known as PGF2-alpha. What is the mechanism of action of latanoprost? The mechanism of action of latanoprost is to increase outflow of the aqueous humor. What is a side effect caused by latanoprost? The side effect that can be caused by latanoprost is that it will darken color of the iris, and this is known as browning. Name all the opioid analgesics. The opioid analgesics are morphine, fentanyl, codeine, heroin, methadone, meperidine, dextromethorphan, and diphenhoxylate. Name the opioid receptors. The opioid receptors are mu receptors, which is for morphine, delta receptors, which is for enkephalin, and kappa receptors, which is for dynorphin. What is the mechanism of action of opioid analgesics? The mechanism of action of opioid analgesic is to act as agonist at opioid receptor to modulate synaptic transmission. What happens when opioids act as agonists at opioid receptors? When they act as agonists at opioid receptors, this leads to opening of the potassium channel and closing of the calcium channel. This leads to decrease in synaptic transmission. Name all the neurotransmitters whose release is inhibited by opioids. Opioids inhibit release of acetylcholine, norepinephrine, serotonin, glutamate, and substance P. What are all the clinical uses of opioids? Opioids are used in the treatment of pain management, cough suppression, diarrhea, acute pulmonary edema, and maintenance programs for addicts. Name an opioid that's a cough suppressant. An opioid that's a cough suppressant is dextromethorphan. What are the opioids used in the treatment of diarrhea? The opioid used in the treatment of diarrhea is loperamide and diphenhoxylate. Name the opioid that's used in the maintenance program for addicts. The opioid that's used in maintenance program is methadone. What are all the side effects and toxicities of opioids? The side effects and toxicities of opioids include addiction, respiratory depression, constipation, miosis, which would lead to the pinpoint pupils, and additive CNS depression with other drugs. Tolerance to what condition is not developed in opioid use? Tolerance does not develop to meiosis and constipation with opioid use. What are the drugs used to reverse toxicities of opioids? The drugs used to treat toxicities of opioids are naloxone and naltrexone, which are opioid receptor antagonists. What is the mechanism of action of butorphanol? The mechanism of action of butorphanol is to produce analgesia, and this is done because it's a mu opioid receptor partial agonist and a kappa opioid receptor agonist. What are the clinical uses of butorphanol? The clinical use of butorphanol is to manage severe pain, such as in migraine and when a person is going through labor. What is the benefit of using butorphanol over using a full opioid agonist? The benefit of using butorphanol, which is a partial mu opioid receptor agonist, is because this drug will cause less respiratory depression. What are the side effects and toxicities of butorphanol? The side effects and toxicities of butorphanol is that it can cause opioid withdrawal syndrome if the patient is also taking a full opioid agonist. And the reason for this is because that would create competition for the opioid receptors. One other thing to note about this drug is that the overdose of this drug is not easily reversed with naloxone. And again, the reason for that is also the same because this is only a partial agonist at mu opioid receptor. What is tramadol? Tramadol is a very weak opioid agonist. What is the mechanism of action of tramadol? The mechanism of action of tramadol is to inhibit serotonin and norepinephrine reuptake. What is the mnemonic to help you remember tramadol? The mnemonic to help you remember tramadol is just remember tram it all, and that's because it works on inhibiting multiple neurotransmitters. What is the clinical use of tramadol? The clinical use of tramadol is to manage chronic pain. What are the toxicities and side effects of tramadol use? The side effects and toxicities of tramadol use is similar to opioids, and it also decreases seizure threshold. Epilepsy drugs. What type of seizures is phenytoin used for? Phenytoin is used for both simple and complex partial seizures, and it's a first-line drug for tonic-clonic seizures, and it's first-line for prophylaxis of status epilepticus. What is the mechanism of action of phenytoin? The mechanism of action of phenytoin is to increase sodium channel inactivation. What is the name of phenytoin prodrug that is used parenterally in hospitals to work like phenytoin? The drug is fosphenytoin. What types of seizures is carbamazepine used for? Carbamazepine is a first-line drug in simple and complex partial seizures, as well as first-line drug in tonic-clonic seizures. What is the mechanism of action of carbamazepine? The mechanism of action of carbamazepine is to increase sodium channel inactivation. What condition is carbamazepine a drug of choice for? Carbamazepine is the drug of choice for trigeminal neuralgia. What types of seizures is lamotrigine used for? Lamotrigine can be used for simple and complex partial seizures, along with tonic-clonic generalized seizure. What is the mechanism of action of lamotrigine? The mechanism of action of lamotrigine is to block voltage-gated sodium channels. What types of seizures is gabapentin used for? Gabapentin, just like lamotrigine, is used for simple and complex partial seizures, along with tonic-clonic generalized seizures. What is the mechanism of action of gabapentin? Gabapentin is designed as a GABA analog, but it primarily inhibits high-voltage activated calcium channels. Name some other condition in which gabapentin is used. Other condition in which gabapentin is used is in peripheral neuropathy, postherpetic neuralgia, migraine prophylaxis, and in bipolar disorders. What is peripheral neuropathy? Peripheral neuropathy is just a condition in which there is damages to the nerves of the peripheral nervous system. What is postherpetic neuralgia? Postherpetic neuralgia is nerve pain due to damage caused by varicella-zoster virus and shingles. What types of seizures is topiramate used for? Topiramate, just like lamotrigine and gabapentin, is used for simple and complex partial seizures as well as tonic-clonic seizures. What is the mechanism of action of topiramate? The mechanism of action of topiramate is to block the sodium channels and to increase GABA action. What are some other uses of topiramate? Topiramate is also used for migraine prevention. What types of seizures is phenobarbital used for? Phenobarbital, just like topiramate, gabapentin, and lamotrigine, is used for simple and complex partial seizures as well as tonic-clonic generalized seizures. What is the mechanism of action of phenobarbital? The mechanism of action of phenobarbital is to increase GABA A action. What is the primary use of phenobarbital? Phenobarbital is used as a first-line drug in children with epilepsy. What types of seizures is valproic acid used for? Valproic acid can be used in simple and complex partial seizures. It's a first-line drug for tonic-clonic seizures, and it can also be used in absent seizures. What is the mechanism of action of valproic acid? The mechanism of action of valproic acid is to increase sodium channel inactivation and increase GABA concentration. What other type of seizures is valproic acid used for? Valproic acid can also be used in myoclonic seizures. What are myoclonic seizures? Myoclonic seizures are rapid, brief contraction of bodily muscles which usually occur at the same time on both sides of the body. What types of seizures is ethosuximide used for? Ethosuximide is a first-line drug in absent seizures. What is the mechanism of action of ethosuximide? The mechanism of action of ethosuximide is to block the thalamic T-type calcium channels. Name the benzodiazepines that are used as first-line drugs for acute status epilepticus. Benzodiazepines that are first-line drugs for acute status epilepticus includes diazepam or lorazepam. What is the mechanism of action of benzodiazepines? The mechanism of action of benzodiazepines is to increase GABA A action. What other types of seizures can benzodiazepines be used for? Benzodiazepines can also be used for seizures of eclampsia. What is eclampsia? Eclampsia is a condition in which one or more convulsions occur in a pregnant woman suffering from high blood pressure. In this condition, following convulsions, the patient usually goes into a coma, and it poses a great risk to the health of the mother and the baby. What is the first-line drug used in the treatment of eclampsia? The first-line drug used in the treatment of eclampsia is magnesium sulfate. What types of seizures is tiagabine used for? Tiagabine is used in simple and complex partial seizures. What is the mechanism of action of tiagabine? The mechanism of action of tiagabine is to inhibit GABA reuptake. What types of seizures is vigabatrin used for? Vigabatrin, just like tiagabine, is used for simple and complex partial seizures. What is the mechanism of action of vigabatrin? The mechanism of action of vigabatrin is to irreversibly inhibit GABA transaminase, and when there is inhibition of GABA transaminase, that means reduction of GABA is not occurring, and that would in turn lead to increase in the levels of GABA. What types of seizures is levetiracetam used for? Levetiracetam is used for simple and complex partial seizures as well as tonic-clonic seizures. What is the mechanism of action of levetiracetam? The mechanism of action of levetiracetam is unknown, but it may modulate GABA and glutamate release. First-line drugs in epilepsy treatment. What is the first-line drug used in the treatment of simple and complex partial seizures? The first-line drug used in the treatment of simple and complex partial seizure is carbamazepine. What are the three first-line drugs used in the treatment of tonic-clonic generalized seizure? The three first-line drugs used in the treatment of tonic-clonic seizure include phenytoin, carbamazepine, and valproic acid. What is the first-line drug used in the treatment of absence generalized seizure? In absence seizures, the first-line drug is ethosuximide. What is the first-line drug used to treat acute status epilepticus? The first-line drug used to treat acute status epilepticus is benzodiazepines such as diazepam or lorazepam. What is the first-line drug used as a prophylactic in status epilepticus? The first-line drug used as a prophylactic in status epilepticus is phenytoin. Epilepsy drug toxicities. What are all the toxicities observed in benzodiazepines? The toxicities of benzodiazepines include sedation, tolerance, and dependence. What are the toxicities observed with carbamazepine? The toxicities observed with carbamazepine includes diplopia, ataxia, blood dyscrasia such as agranulocytosis or aplastic anemia, liver toxicity, teratogenesis, induction of cytochrome P450, SIADH, and Stevens-Johnson syndrome. What is blood dyscrasia? Blood dyscrasia just means that there is something that's not right in the blood. It can include an increase or decrease in the total number of red blood cells, which would either be polycythemia or anemia. There can also be abnormal or neoplastic white blood cells, such as leukemias, or it can also be abnormal or insufficient platelets, and that can be either coagulopathy or thrombocytopenia. So any of these discrepancies is considered blood dyscrasia. What is teratogenic drug? Teratogenic drug is just a drug that should not be used during pregnancy because it may cause some sort of damage or harm to the unborn baby. What is SIADH? SIADH just stands for Syndrome of Inappropriate Antidiuretic Hormone, and this is characterized by excessive release of antidiuretic hormone from the posterior pituitary gland. Describe what all occurs in Stevens-Johnson syndrome. In Stevens-Johnson syndrome, it starts off with malaise and fever, and then that's followed by onset of erythematous and purpuric macules, and those macules are going to be found in the mouth, in the eye, and even the genitals. And after the skin lesions, it's going to progress into epidermal necrosis and sloughing. And sloughing just means shedding of the skin. What are the toxicities seen with ethosuximide use? With ethosuximide, the toxicities include GI distress, fatigue, headache, urticaria, and Stevens-Johnson syndrome. What is urticaria? Urticaria, also known as hives, are raised, often itchy red welts on surface of the skin. What is the mnemonic to help you remember the toxicities of ethosuximide? The mnemonic to help you remember this is just remember EFGH. And E stands for ethosuximide, F stands for fatigue, G stands for GI distress, and H stands for headache. What are the toxicities of phenobarbital use? The toxicities of phenobarbital use include sedation, tolerance, dependence, and induction of cytochrome P450. What are the toxicities observed with phenytoin use? There are lots of toxicities associated with phenytoin use, including nystagmus, diplopia, ataxia, sedation, gingival hyperplasia, hirsutism, megaloblastic anemia. It's also a teratogenic drug because it leads to fetal hydantoin syndrome. It also leads to lupus-like syndrome, induction of cytochrome P450, lymphadenopathy, Stevens-Johnson syndrome, and osteopenia. What are all the toxicities of valproic acid? The toxicities of valproic acid includes GI distress, rare but fatal hepatotoxicity, neural tube defect in the fetus, and that leads to spina bifida, tremors, and weight gain. This drug is contraindicated in pregnancy. What are the toxicities seen with lamotrigine? The toxicities in lamotrigine is Stevens-Johnson syndrome. What are the toxicities observed in gabapentin? The toxicities of gabapentin include sedation and ataxia. What are the toxicities observed with topiramate? The toxicities in topiramate include sedation, mental dulling, kidney stones, and weight loss. What is the mechanism of action of phenytoin? The mechanism of action of phenytoin is to cause a use-dependent blockade of the sodium channels. It also causes inhibition of glutamate release from the excitatory presynaptic neuron. What is the clinical use of phenytoin? The primary clinical use of phenytoin is to treat tonic-clonic seizures. This drug is also considered a class 1B antiarrhythmic. What are the toxicities of phenytoin? We have already talked about this, but we will go over it one more time. The toxicities of phenytoin includes nystagmus, ataxia, diplopia, sedation, lupus-like syndrome, and this drug can induce cytochrome P450. Chronic use of this drug can lead to gingival hyperplasia in children. It can also lead to peripheral neuropathy, hirsutism, megaloblastic anemia due to decrease in folate absorption, and it's a teratogenic drug because it causes fetal hydantoin syndrome. What is fetal hydantoin syndrome? Fetal hydantoin syndrome is a condition that is caused when taking phenytoin during pregnancy, and this will lead to intrauterine growth restriction with microcephaly and will develop minor dysmorphic craniofacial features with limb defects including hypoplastic nails and distal phalanges. Name some barbiturates. Barbiturates includes phenobarbital, pentobarbital, thiopental, and saccobarbital. What is the mechanism of action of barbiturates? The mechanism of action of barbiturates is to facilitate GABA-A action by increasing the duration of the chloride channel opening, and this leads to decrease in the neuron firing. What is the mnemonic to help you remember the mechanism of action of barbiturates? Just remember barbiturates because it has the word durates in it. It increases duration of the chloride channel opening. In what condition are barbiturates contraindicated? Barbiturates are contraindicated in porphyrias. What are porphyrias? Porphyrias are a rare inherited disorder in which an important part of hemoglobin called heme is not made properly, and this results in neurological complications or skin problems, or occasionally both. What are the clinical uses of barbiturates? Barbiturates can be used as a sedative for anxiety. It can also be used in seizures, insomnia, and for induction of anesthesia, and the drug to do that is thiopental. What are the toxicities of barbiturates? We already talked about this part, but we will mention it one more time. In barbiturates, the toxicities include respiratory and cardiovascular depression, which can be fatal, CNS depression, which can be exacerbated by alcohol use, so you never want to mix the two. Barbiturate can also lead to dependence of the drug. Drug interactions can also happen because it induces cytochrome P450. And in cases of overdose, the treatment is supportive, and in this there would be requirement of respiration support and maintenance of blood pressure. Name some benzodiazepines. Benzodiazepines includes diazepam, lorazepam, triazolam, temazepam, oxazepam, midazolam, chlordiazepoxide, and alprazolam. What is the mechanism of action of benzodiazepines? The mechanism of action of benzodiazepine is to facilitate GABA-A action by increasing frequency of chloride channel opening. They can also decrease REM sleep. Name the benzodiazepines that do not have long half-lives and do not have active metabolites. Benzodiazepines such as triazolam, oxazepam, and midazolam are short-acting. They also do not have active metabolites, and these have higher additive potential. What is the mnemonic to help you remember that benzodiazepines increases the frequency? The mnemonic is just remember benzodiazepines as frenzodiazepines because they increase frequency. What are all the groups of drugs that bind to GABA-A receptor? The groups of drugs that bind to GABA-A receptors includes benzos, barbs, and alcohol. And these GABA-A receptors are ligand-gated chloride channels. What are all the clinical uses of benzodiazepines? The clinical uses of benzodiazepines is for anxiety, spasticity, status epilepticus such as lorazepam and diazepam is used for that. Also detoxification such as an alcohol withdrawal syndrome that leads to delirium tremens. Benzodiazepines are also used in night terror, sleepwalking, and also as general anesthesia because they cause amnesia and muscle relaxation. And lastly, they can also be used as an hypnotic agent to treat insomnia. What is delirium tremens? Delirium tremens is a severe form of alcohol withdrawal that involves sudden and severe mental or nervous system changes. What are all the toxicities and side effects of benzodiazepine use? The side effects and toxicities of benzodiazepine use includes dependence, and they also have additive CNS depression effects with alcohol. Why are benzodiazepines safer than barbiturates? The reason benzodiazepines are considered safer than barbiturates is because they have less risk of respiratory depression and coma than barbiturates do. What drug is used to treat benzodiazepine overdose and why? The drug that's used to treat benzodiazepine overdose is flumazenil. And the reason this drug can be used is because it's a competitive antagonist at GABA benzodiazepine receptor. So because it's a competitive antagonist, it will just replace the benzodiazepines with itself, and that will cause a reversal of overdose. Name the non-benzodiazepine hypnotics. The non-benzodiazepine hypnotics include zolpidem, which is known as the brand name Ambien, zolpidem, and ezopiclone. What is the mechanism of action of non-benzodiazepine hypnotics? The mechanism of action of non-benzodiazepine hypnotics is to act via the BZ1 subtype of the GABA receptor. What drug can be used to reverse the effect of non-benzodiazepine hypnotics? Just like with benzodiazepines, you could still use flumazenil to reverse the effect of non-benzodiazepine hypnotics. What is the clinical use of non-benzodiazepine hypnotics? The clinical use of non-benzodiazepine hypnotics is to treat insomnia. What are the toxicities associated with non-benzodiazepine hypnotics? The toxicities of non-benzodiazepine hypnotics includes ataxia, headaches, and confusion. Describe the duration of action of non-benzodiazepine hypnotics. Non-benzodiazepine hypnotics have short duration because of rapid metabolism by liver enzymes. And unlike other sedative hypnotics, they only cause modest day-after psychomotor depression and few amnestic effects. They also have lower dependence risk than benzodiazepines. Anesthetics general principles. What is a general rule for a CNS drug to cross the blood-brain barrier? A CNS drug must be liposoluble to cross the blood-brain barrier or be actively transported. What does a drug with low solubility in blood indicate? A drug that has low solubility in blood indicates that it has a rapid induction and rapid recovery time. What does a drug with high solubility in lipids indicate? A drug with high solubility in lipids indicates that it's highly potent, which equals 1 over the minimal alveolar concentration. What is MAC? MAC stands for minimal alveolar concentration, at which 50% of the population is anesthetized, and this varies with age. Describe the anesthetic general principles of nitrous oxide. The anesthetic general principles of nitrous oxide is that it has low blood and lipid solubility, so this means that it has fast induction and recovery times but low potency. Describe the anesthetic general principle of halothane. The anesthetic general principle of halothane is that it has high lipid and blood solubility, so this means that it has high potency but slow induction. Name some inhaled anesthetics. The inhaled anesthetics includes halothane, enflurane, isoflurane, sevoflurane, methoxyflurane, and nitrous oxide. What is the mechanism of action of the inhaled anesthetics? The mechanism of action of this is generally considered to be unknown. What are the effects of inhaled anesthetics? The effects of inhaled anesthetics includes myocardial depression, respiratory depression, nausea, emesis, and it increases cerebral blood flow but decreases the cerebral metabolic demand. What are the toxicities associated with inhaled anesthetics? The toxicities that is caused by inhaled anesthetics is hepatotoxicity, which can be caused by halothane, nephrotoxicity, which is caused by methoxyflurane, convulsions, which can be caused by enflurane, malignant hyperthermia, which is caused by all the inhaled anesthetics except for nitrous oxide, and malignant hyperthermia is a rare condition, but it can be life-threatening, and the susceptibility to this is inherited. And with inhaled anesthetics, there can be expansion of the trapped gas in the body cavity, which occurs with nitrous oxide. Name the groups of drugs that can be used as intravenous anesthetics. The groups of drugs that can be used as intravenous anesthetics includes barbiturates, benzodiazepines, aryl cyclohexamines, opioids, and propofol. What is the mnemonic to help you remember the groups of drugs that can be used as intravenous anesthetic? The mnemonic to remember this is just remember B.B. King on opioid proposes foolishly. The first B standing for barbiturates, the second B standing for benzodiazepine, K in King standing for ketamine, which is the aryl cyclohexamine, and opioids proposes foolishly is for opioids and propofol. Name the barbiturate that can be used as intravenous anesthetic. The barbiturate that's used for this is thiopental. Describe the anesthetic features of thiopental. Thiopental is a high potent drug, it's highly lipid soluble, and it has rapid entry into the brain. Thiopental is used for induction of anesthesia and short surgical procedures. The effects of thiopental is terminated by rapid redistribution into the tissues such as in the skeletal muscle and fats. Thiopental does also decreases the cerebral blood flow. What are all the clinical uses and features of the benzodiazepine midazolam? Midazolam is an intravenous anesthetic. It's the most common drug used for endoscopy. It's used adjunctively with gaseous anesthetics and narcotics. It may also cause severe post-operative respiratory depression along with decrease in blood pressure, which can be treated with flumazenil. And lastly, midazolam can cause amnesia. What is ketamine? Ketamine is phencyclidine analog that acts as dissociative anesthetic. What is the mechanism of action of ketamine? The mechanism of action of ketamine is to block the NMDA receptors. What are the side effects of ketamine use? Ketamine use can lead to cardiovascular stimulation. It can also cause disorientation, hallucination, and bad dreams. What effect does ketamine have on the cerebral blood flow? Ketamine can increase the cerebral blood flow. Name the opioids that are used as intravenous anesthetics. Opioids that are used as intravenous anesthetic includes morphine and fentanyl is generally used with other CNS depressant during general anesthesia. What are the clinical uses of propofol? Propofol is an intravenous anesthetic agent that is used for sedation in ICU. It causes rapid anesthesia induction and it's used in short procedures. What are some additional features of propofol? Propofol has less post-operative nausea than thiopental does, and it also potentiates GABA A. One additional note that will help you remember propofol is that this is the drug that killed Michael Jackson. So it says here as a side note that this drug is not recommended for home use by pop stars. What are the local anesthetics that are esters? The local anesthetics that are esters includes procaine, cocaine, and tetracaine. What are the local anesthetics that are amides? The local anesthetics that are amides includes lidocaine, mepivacaine, and bupivacaine. What is the mnemonic to help you remember amides local anesthetics? The mnemonic to help you remember this is that amides have two I's in them. So that's lidocaine, mepivacaine, and bupivacaine all have two I's in them. What is the mechanism of action of local anesthetics? The mechanism of action is to block the sodium channels by binding to specific receptors on inner portion of channels. And the local anesthetics preferentially binds to activated sodium channels, so these drugs are more effective in rapid-firing neurons. Describe the mechanism of action of tertiary amine local anesthetics. Tertiary amine local anesthetics penetrate membrane in uncharged form, and then it binds to ion channels as charged form. What drug is given along with local anesthetics to increase the effectiveness of the local anesthesia? Local anesthetics can be given with vasoconstrictors such as epinephrine to enhance their action, and the reason for this is because of vasoconstrictors there would be decrease in bleeding, and it also increases anesthesia effect by decreasing the systemic concentration. Describe why in infected or acidic tissue there is more anesthesia that's needed. In infected or acidic tissue there is more anesthesia that's required because alkaline anesthetics are charged and they cannot penetrate membrane effectively. So because of this, there is need for more anesthetic. Describe the order of nerve blockade with local anesthetics. The nerve blockade happens faster in small diameter fibers than in large diameter fibers, and myelinated fibers than in unmyelinated fibers. But overall, the size factor predominates over myelination, so overall the order of nerve blockade goes small myelinated fibers, followed by small unmyelinated fibers, followed by large myelinated fibers, and then large unmyelinated fibers. What is the order of sensation loss with local anesthesia, naming them from the earliest sensation loss to the latest sensation loss? The first sensation loss with local anesthesia goes pain, followed by temperature, then it's touch, and finally pressure. What is the clinical use of local anesthesia? Local anesthesia is used in minor surgical procedures as well as final anesthesia. What local anesthesias are given if a patient is allergic to esters anesthesia? If a patient is allergic to esters local anesthetics, then you give them amides. What are the side effects and toxicities observed with local anesthetics? Local anesthetics can lead to CNS excitation, severe cardiovascular toxicity that happens with bupivacaine. Hypertension can also occur along with hypotension and arrhythmias can occur with cocaine use. What is the use of neuromuscular blocking drugs? Neuromuscular blocking drugs are used for muscle paralysis in surgery or mechanical ventilation. What type of receptor are neuromuscular blocking drugs selective for? Neuromuscular blocking drugs are selective for motor nicotinic receptors. What are the two types of neuromuscular blocking drugs? The two types of neuromuscular blocking drugs include depolarizing neuromuscular blocking drugs and non-depolarizing. Name a depolarizing neuromuscular blocking drug. A depolarizing neuromuscular blocking drug is succinylcholine. What is succinylcholine? Succinylcholine is a strong acetylcholine receptor agonist, and it produces sustained depolarization and prevents muscle contraction. What is phase 1 block of succinylcholine? The phase 1 block of succinylcholine is the prolonged depolarization phase. What is the antidote to reverse phase 1 succinylcholine block? There is no antidote for this. What group of drugs can potentiate the effect of phase 1 succinylcholine block? Phase 1 block can be potentiated by cholinesterase inhibitors. What is the phase 2 block of succinylcholine? Phase 2 block is when the cells are repolarized but they're still blocked. The reason for this is because the ACH receptors become available at this point, but they are desensitized. What is the antidote of phase 2 block of succinylcholine? The antidote of phase 2 block of succinylcholine is cholinesterase inhibitor. Name a cholinesterase inhibitor. A cholinesterase inhibitor is neostigmine. What are some side effects and complications that can arise due to succinylcholine use? Side effects and complications of succinylcholine use includes hypercalcemia, hyperkalemia, and malignant hyperthermia. What is hyperkalemia? Hyperkalemia is high levels of potassium in the circulating blood. Name some non-depolarizing neuromuscular blocking drugs. The non-depolarizing neuromuscular blocking drugs includes tubocurarine, atracurium, mivacurium, pancuronium, vicuronium, and rocuronium. What is the mechanism of action of non-depolarizing neuromuscular blocking drugs? The mechanism of action of these are to be a competitive antagonist, and these drugs compete with acetylcholine for receptors. What drugs can reverse the effect of non-depolarizing neuromuscular blocking drugs? The drugs that can do this includes neostigmine, edrophonium, and other cholinesterase inhibitors. What is the mechanism of action of dantrolene? The mechanism of action of dantrolene is to prevent the release of calcium from the sarcoplasmic reticulum of the skeletal muscle. What is the clinical use of dantrolene? Dantrolene is used in the treatment of malignant hyperthermia and to treat neuroleptic malignant syndrome. What is malignant hyperthermia? Malignant hyperthermia is a rare but life-threatening side effect of succinylcholine and inhaled anesthetics except for nitrous oxide. And in this condition, there is high body temperature and muscle rigidity. What is neuroleptic malignant syndrome? Neuroleptic malignant syndrome is similar to malignant hyperthermia, but this condition is caused by antipsychotic drugs, and even in this condition, there is muscle rigidity, fever, and autonomic instability. What is Parkinson's disease? Parkinson's disease is a degenerative disorder of the central nervous system in which there is loss of dopaminergic neurons and excess cholinergic activity. What types of drugs are useful in the treatment of Parkinson's disease? Parkinson's disease is treated with drugs that are dopamine agonists. Parkinson also can be treated with drugs that increase dopamine level or the ones that prevent dopamine breakdown, and can also be treated with drugs that decrease cholinergic activity. Name the drugs used in the treatment of Parkinson's disease that are dopamine agonists. The dopamine agonist used in the treatment of Parkinson's disease includes bromocriptine, which is an ergot, pramipexole, and ropinirole. And ropinirole is a non-ergot, and non-ergots are preferred here. What is ergot? Ergot is a type of fungus that occurs on rye. What are the drugs that can increase dopamine levels to treat Parkinson's disease? The drugs to increase dopamine levels used in the treatment of Parkinson's disease are amantadine and the combination of L-dopa and carbidopa. What is the mechanism of action of amantadine used in Parkinson's disease? The mechanism of action of amantadine used in Parkinson's disease is to increase the level of dopamine, and this drug may also increase dopamine release. What are some other conditions in which amantadine can be used? Amantadine can also be used as an antiviral agent against influenza A and to treat rubella. What are the side effects or toxicities of amantadine? The side effects or toxicities of amantadine is ataxia. How does L-dopa and carbidopa work in the treatment to increase dopamine? L-dopa and carbidopa are converted into dopamine when they get to the CNS. Name the drugs that prevent dopamine breakdown used in the treatment of Parkinson's disease. The drugs that prevent dopamine breakdown used in the treatment of Parkinson's disease include selegiline, entacapone, and tolcapone. What is the mechanism of action of selegiline? The mechanism of action of selegiline is that it's a selective MAO type B inhibitor, and MAO stands for monoamine oxidase, so it's a selective monoamine oxidase type B inhibitor. What is the mechanism of action of entacapone or tolcapone? The mechanism of action of entacapone or tolcapone is that they are COMT inhibitors. And COMT stands for catechol-O-methyltransferase, and when that enzyme is inhibited, it prevents L-DOPA degradation. So if you're preventing L-DOPA breakdown, this would lead to increased dopamine availability. What drugs are used in the treatment of Parkinson's disease to decrease excess cholinergic activity? The drug used to decrease excess cholinergic activity is benztropine. What is the mechanism of action of benztropine? Benztropine is an anti-muscarinic agent. What symptoms of Parkinson's are prevented by benztropine? Benztropine prevents tremors and rigidity, but it has little effects on bradykinesia. What is the mnemonic to help you remember that benztropine can be used in the treatment of Parkinson's disease? The mnemonic to help you remember this is just remember, park your Mercedes-Benz. So that's park is for Parkinson's and Benz is for benztropine. What is the mnemonic to help you remember all the drugs used in the treatment of Parkinson's disease? The mnemonic to help you remember this is just remember BALSA, balsa. And that B standing for bromocriptine, A standing for amantadine, L standing for levodopa or L-dopa, which is usually given with carbidopa, the S which stands for selegiline, which prevents dopamine breakdown along with COMT inhibitors, and the last A standing for antimuscarinics. What drug is used in the treatment of essential or familial tremors? For essential or familial tremors, use a beta blocker like propranolol. What is the mechanism of action of L-dopa or levodopa and carbidopa? The mechanism of action of this combination is to increase level of dopamine in the brain. Describe how L-dopa and carbidopa combination becomes dopamine in the CNS. The way this happens is unlike dopamine, L-dopa can easily cross the blood-brain barrier, and there, by the enzyme dopa decarboxylase, it's converted into dopamine in the CNS. Why is carbidopa given along with L-dopa? The reason carbidopa is given along with L-dopa is because it's a peripheral decarboxylase inhibitor, and when given with L-dopa, it increases the bioavailability of L-dopa in the brain, and carbidopa also limits peripheral side effects of L-dopa. What is the clinical use of L-dopa and carbidopa combination? The clinical use of this is for Parkinson's disease. What are the toxicities associated with L-dopa-carbidopa combination? This L-dopa or levodopa and carbidopa combination can lead to arrhythmias from increased peripheral formation of catecholamines, and the long-term use of these drugs can lead to dyskinesia following administration and akinesia between doses. What is dyskinesia? Dyskinesia is abnormality or impairment of voluntary movements. What is akinesia? Akinesia is a complete loss of voluntary movements. What is the mechanism of action of selegiline? The mechanism of action of selegiline is to selectively inhibit MAO-B, which is monoamine oxidase B. And normally, MAO-B is what metabolizes dopamine over norepinephrine and serotonin. So when you inhibit the enzyme MAO-B, it would increase the availability of dopamine. What is the clinical use of selegiline? The use of selegiline is to be used along with L-dopa in the treatment of Parkinson's disease. What are the side effects and toxicities of selegiline use? Selegiline use may enhance the adverse effects of L-dopa. What is the mechanism of action of the Alzheimer's drug memantine? Memantidine is an NMDA receptor antagonist. This drug helps prevent excitotoxicity, which is mediated by calcium. What are the side effects and toxicities of memantine? The side effects and toxicities of memantine includes dizziness, confusion, and hallucinations. Name some acetylcholine esterase inhibitors. The acetylcholine esterase inhibitors includes donepezil, galantamine, and rivastigmine. What are the side effects and toxicities of acetylcholine esterase inhibitors? The side effects and toxicities of acetylcholine esterase inhibitors includes nausea, dizziness, and insomnia. What are the neurotransmitter changes that occurs in Huntington's disease? In Huntington's disease, there is decrease in the level of GABA, there is decrease in acetylcholine, and there is an increase in dopamine. What are the drugs used in the treatment of Huntington's disease? The drugs used in the treatment of Huntington's disease includes tetrabenazine, reserpine, and haloperidol. What is the mechanism of action of tetrabenazine and reserpine? The mechanism of action of tetrabenazine and reserpine is to inhibit VMAT, and VMAT stands for vesicular monoamine transporter. And so when that gets inhibited, it would also limit the dopamine vesicle packing and release. What is the mechanism of action of haloperidol? Haloperidol is a dopamine receptor antagonist. What is sumatriptan? Sumatriptan is a serotonin 5-HT1B and 5-HT1D agonist. Sumatriptan also inhibits the trigeminal nerve activation, it prevents vasoactive peptide release, and it induces vasoconstriction. What is the half-life of sumatriptan? The half-life of sumatriptan is less than 2 hours. What are the clinical uses of sumatriptan? Sumatriptan is used in acute migraines and cluster headache attacks. What is the mnemonic to help you remember the clinical uses of sumatriptan? Just remember, a sumo wrestler trips and falls on your head. What are the side effects and toxicities of sumatriptan? Sumatriptan can lead to mild tingling and coronary vasospasms, and because of coronary artery disease, this drug is contraindicated in patients with coronary artery disease or Prinzmetal's angina. That is the end of the neurology chapter.